every time, don't know what to say. The part of you that stays, it's the part that runs away. I'll never find some peace of mind. What do you want from me? If you don't love me back, to set me free.
Hello. Very good evening, sir. Very good evening, Claire, sir.
Yeah, can you hear me?
Yes, sir. So Anup sir is here, sir. I think he will coordinate the session.
Sir, morning.
Good morning. How are you?
Good, good, good. Missed you. कहाँ पे चंडीगढ़ बैठे हो?
Yeah, yeah.
All well.
All well. Missed
Health,
you seeing
health is fine, na,
guys
sir.
physically.
Health is fine.
Yeah, yeah, everything fine.
Very good, very good. Sir, another 3-4 minutes will start.
Okay. अगली मेरी स्लाइड शो कर देना कैमरा कम हो गया
We have a good time.
Yeah. Wow. इस पे जाऊँ वो बेस्ट टॉप कर मेरा
Good morning, all. Second day of JHRS. We welcome you all in the early morning session. And the first symposium is on pacing symposium. We have very eminent cardiologist and electrophysiologist of the country, Dr. T.S. Clare. He will be talking about conduction system pacing, restoring and physiology. Sir, may I request you to please proceed.
Thank you very much. I'm just trying to share my slides. Just give me a minute. I think you have to do desktop.
Sir, we can see your screen now, so you can start.
Logical pacing is the talk of the town these days, and I thought that is one of the things to be discussed. Now, if you look at this ECG, if I don't write here what I have written here, it will be very difficult for anybody to say that it is it's a paced ECG. It looks like a totally normal QRS complex, and you don't see even the spike because it's a bipolar phase bundle pacing. So this kind of ECG we had not seen in the past after pacing. Here is the just compare. This is the traditional RBD apical pacing, and this is the left bundle pacing. Look at the QRS complex, which is fantastic, normal, around 80 90 milliseconds of QRS. So there is no doubt that what physiological pacing can give us, it cannot, the traditional pacing cannot give. Even otherwise, I think the rule of the nature is that if we mimic nature in whatever medical therapies we do, we'll be better off as compared to we don't follow the nature. The nature has created the conduction system for the activation of the heart. So if we can recruit the conduction system, I think logically also it seems that we will be better off. The interesting thing is that in conduction system pacing, the first seminal paper came from Dr. Narula, and Dr. Narula had shifted from Warren Institute of Medical Sciences to USA. He demonstrated first time that in a patient with, with left bundle block, he could pace the distal his and can get a narrow QRS complex. So then the thinking started that the block, the left bundle block or the right bundle block, they are not distal. Usually most of the patients, they are proximal in the common conduction system. We're lucky to start a conduction system pacing in 2015. We did 4 cases. And after that, for some time, we also lost some interest, but we took it again in a very, very vigorous way in 2017 when the new leader 3830 came available. So this is just a picture to show that this is what happens if you pace the right ventricular apex. So you create dyssynchrony, and we know that dyssynchrony induced by the the right ventricular apical pacing will lead to a left ventricular dysfunction in at least some of the patients. And this is a study many years back to show that right ventricular apical pacing induced left ventricular dysfunction. Here in this trial, in this study, more than 30% of the patients developed more than 5% decrease in LV ejection fraction after high dose of apical RB pacing. High dose means the cutoff figure is usually taken as 40%. If you require more than 40% of the pacing in any patient, you may get left ventricular dysfunction. And overall, the incidence of the apical RB apical pacing induced cardiomyopathy is around 8 to 10%. Of course, there are various figures from various studies, but and on overall, I think around 8 to 10% people they do develop left ventricular dysfunction and heart failure. Now, all these patients in this study, they had a intrinsic QRS was narrow in these patients. So we made it broad by RBI apical pacing. And this was the first paper actually in 2000 when it came distal his bundle pacing in heart failure with atrial fibrillation. This was a ablate and pace trial, atrial fibrillation, fast ventricular response, and heart failure patients. So they ablated the AV node and they gave the distal his bundle pacing. It was a fixed screw stillet driven lead in this trial by Deshmukh et al. And it showed that the ejection fraction, left ventricular diastolic dimension, everything was better if we paced the distal hustle in these patients. So this was a positive trial in favor of physiological pacing. Very shortly, the people realized some of the difficulties in pacing the his bundle, because first of all, his bundle is a very small area. It's a fibrous structure and difficult to get in. Some of the patients needs more experience. Plus, the R waves are not adequate. Not only that, even the long-term reliability is a question in these patients when we pace the distal his. So then people started looking at the pacing of the left bundle, and this is a study into 2020 by Padala et al. To show that left bundle pacing is better approach to physiological pacing and easier also. Uh, there are many patients, from many trials were taken in this different kind of subsets, sinus node disease, AV block, left bundle block, heart failure patient. All of these patients, they showed that left bundle pacing is a better approach. So this is another study to show the long-term safety and feasibility of the left bundle pacing. This was a large study, 618 patients, and various types of sets, AV node block with atrial fibrillation, with AV node ablation, and there was a intranodal block in some of the patients, like six sinus disease patients, and this study. Uh, So these are various all patient left bundle AV node block, atrial fibrillation plus AV node ablation and sinus node disease. And it showed that the thresholds were pretty stable. If you see the study here over followed up to 2 years, the R waves amplitude, they remained better, the impedances remained stable. Not only that, if you compare with the baseline, the ejection fraction improved, and of course it will not improve when the patients are in sinus, because already there is a narrow KRS complex. But other categories, there was clear indication that the physiologically the ventricular function is better in physiological left bundle pacing. Even the incidence of severe tricuspid regurgitation was less with this as compared to with the routine pacing. So what about the complications? Because this is a large trial, so I thought I will share with you. Very few actually. Septal perforation, two patients, intravenous puncture-related injury that can happen in any kind of pacing, coronary artery injury, none, and six increase of threshold more than 2 or 3 volt was only 6 patients, and there was loss of capture in 2 patients out of out of 618, which is I think not much. Rest lead pocket infection, hematoma, septal perforation only during follow-up. This was during procedure. This was during follow-up. During follow-up, one patient. So few complications. So now, this is we are talking about Brady indications, but if we see our CRT results from various trials, Miracle 2, Prospect, Freedom, we all know that the response rate of traditional CRT is around 65% to the best possible figure. Uh, Now, we also know that SCAR limits response in left bundle branch block patients. And if your patient is a typical left bundle QRS more than 150, female, non-ischemic, you have demonstrated mechanical dyskinesia, these patients respond much better to CRT, traditional CRT. But if you have a ischemic or you have a large scar tissue, non-left bundle patients, right bundle patients, these patients, they don't really respond to CRT. So that means there is a scope of improvement, and we have a unmet need to improve our results of CRT. So if we see the conduction system here, these blocks, as I told you, this is a common conduction area, his bundle area. Then it divides into the left bundle and the right bundle. Most of the blocks are proximal. So if you pace distal to the block, you could recruit the normal conduction system, and further on, the conduction and the conduction in the his Purkinje system is normal, thus giving you a physiological kind of pacing. This was a trial in 2015, one of the earlier trials where these patients did the distal his bundle lead. They also did the traditional CRT, but there was a adapter. They could either pace with distal bundle alone or traditional CRT, and there was a 1 month, then 6 month, then changeover to the other modality. Anyway, this trial showed that his bundle pacing was as effective as traditional CRT. Uh, Now, another story is that there is no trial so far which has shown any positive effect in typical right bundle patients with cardiomyopathy. If you have a typical right bundle, these patients really don't benefit. Of course, if you have a atypical right bundle, there some of these patients are masked left bundle, though those patients may improve, but typical right bundle doesn't improve. So this is a trial by Sharma et al. In 2018, where they did his bundle pacing in a patient with the right bundle block. They could recruit the right bundle in 78% of the patients, and very surprisingly, there was an overall 10% improvement in ejection fraction in these patients. This is the data shown on the right side. The basic ejection fraction less than 35%, and p-values are highly, highly significant. So this is very encouraging to note that if you have a cardiomyopathy with right bundle block, so you go for physiological pacing rather than traditional CRT. The same trial, average QRS narrowing was 30 milliseconds, so and 20% by his bundle pacing in these patients. Uh, if you see, this is a meta-analysis of his bundle pacing. This is his bundle pacing in heart failure patients, and there are 4 or 5 trials in Deshmukh, Wang, and Vijayaraman. And if you see in these trials, meta-analysis, on an average, there was a 50 millisecond shortening of his paced QRS, and there was no significant change in the capture or the bundle branch correction threshold on follow-up, and overall there was 11% increase in ejection fraction in these patients. Again, showing very beneficial. Am I audible?
Yes,
Hello?
sir. Yes, sir. But your slides has gone off.
Why the slides were on? Nilu, can you help me?
So we can see you. No, we cannot see your slides.
Grant permission. Okay. Okay. Now,
Yes, it is visible.
the visible now?
Yes.
Okay. So the question is that if you in a CRT, if we fail to achieve our goal, then we need to change our strategy, not the goal. The goal in CRT is clearly that we need narrowing of the QRS complex. And why it's not moving? Yeah. Okay. So these are some of the examples I want to show you. Uh, if you see this is a patient for CRT, and this is a typical left bundle pacing with R prime. The same patient being paced in bipolar mode, because in many of these patients the anode can capture the right bundle and you look like a normal ECG in this patient. Uh, Another patient, it was a very wide QRS complex, 230 milliseconds fragmented QRS complex. So we did the left bundle pacing, but that recruited the left bundle, but QRS was still broad, so we put a left ventricular lead. And ultimately, in this patient, with the combination of left ventricular lead and bipolar left ventricular pacing and the left bundle plus LV lead combined, we got QRS narrowing from 230 to 130 milliseconds and extremely good LVAT of 70 milliseconds. Another patient, 196 milliseconds, and this is the same patient actually. I'm showing the left. This was the left bundle pacing. This was the combination of left bundle pacing and the left ventricular lead in these patients. Uh, this is a patient where we did a combined his and left bundle pacing for a patient with left bundle block dilated cardiomyopathy. Uh, in this patient, we put two leads. One was at the his bundle. We could capture the his bundle very nicely, but because we wanted to give him a defibrillator, it was a D device. So the R waves were 3.5. We put another lead into the left bundle, and the R waves were around 10. So we were pacing from the distal haze, but we are sensing from the left bundle lead, so that there is no missing of the ventricular fibrillation in these patients. So if we see the overall, I don't know whether these figures have changed now. This is a little old presentation. I think still in India the penetration of the physiological pacing is less than 10%. Japan is behind, US is around 11%, Europe is at 9%, China is ahead of all of us. I think they have crossed around 20%. This again is our old slide. Now we have around 400 patients actually combined with the Brady indication or with the CRT indication, and our successful recruitment of the conduction system has been around 93%. We had one patient displacement, one patient next day, perforated the into the LV impedance dropping suddenly, and failure of pacing. We withdrew, attempt took a new place. We could successfully do that. One patient, there are two patients where the thresholds have increased to around 3.5 or so, and one patient came with the failure of pacing. We had to replace the lead in these patients. So still very few patients where we had this problem. So my dear friends, if I have to conclude, I will say physiological pacing by either his bundle pacing or by left bundle pacing is can be achieved in more than 90% of the patients. And I tell you, believe me, that the learning curve is not too long. Uh, if you have some knowledge of electrophysiology, then it is useful. But even if you don't have knowledge of electrophysiology, conduction system pacing can still be done. You need 12 lead ECG during your implant, and you need to measure the LVAT and the QRS complex on the screen. For those people who may be new in this audience, LVAT means left ventricular activation time. So this we take from the spike to the peak of the R wave. This tells you how fast is the depolarization of the ventricle. Normally, we would like the LVAT to be around less than 75 or so, around 75, less than 75. So with the experience of various operators, left bundle pacing is becoming more and more famous, because again it is a reliability in a long-term basis, better R waves, and uh, physiological pacing can certainly correct left bundle and achieve CRT in many patients, and where you cannot achieve narrowing of the QRS complex with just conduction system pacing, you add the left ventricular lead. The concept being either the hot CRT or the lot CRT. Hot means his bundle optimize CRT. Lot means left bundle. In fact, in my center, most of the patients we do either nowadays we are doing lots CRT more than the hot CRT. We sometimes we do try for 30 minutes for good his bundle pacing, particularly in those patients where we don't have to use defibrillator. But in patients with CRTD, we directly go to the left bundle because we want a good R waves in these patients. So his bundle or left bundle optimized CRT can achieve benefits of both LB pacing as well as conduction system recruitment. And I think at least the medium term follow-up data looks very promising, and I think it will change the standard of pacing in the future. Thank you very much for your kind attention.
Thank you, Dr. Clare, for an excellent presentation of how a physiological pacing can be further strengthened by decreasing the interventricular dysynchrony as well.
See, I didn't go into the recording of the left potential or his potentials and things of that nature, because I thought there may be physicians in this. But for guys who have the knowledge. In majority of the patients, actually, you can record the, or more than 60% you can record the left bundle potential in these patients.
Sir, couple of questions from my side. One
Yeah.
thing is, do you have any preference for his bundle pacing for a lumenless or a slit-driven versus left bundle pacing? And secondly, if the patient
I prefer 3830.
for both,
Yeah, yeah.
for his bundle as
But
well as
now
left.
recently, we have started using. We started with the Biotronic, and then the Boston has also the. Um, but you cannot. We have never tried Biotronic and Boston for his bundle pacing. At
No,
least
that
we do
that
left
was my
bundle
yeah
pacing.
precisely that was my question. Like, whether you
Right,
want to
right.
try slit-driven for his bundle pacing as well.
Yeah, I think maybe I don't know. Really, it will be very difficult to get distal his bundle pacing with these, leads. Left bundle, yes, you can get it.
And the other question from my side is, suppose the patient is totally dependent on pacing, no escape rhythm. So, suppose you are doing
Directly go to left bundle. Yeah, in
So,
those patients, we
so,
directly go to left bundle.
so do you put a backup, an additional RV lead in those patients? No.
No, 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 not at all.
So
In
you're happy
fact,
with the left bundle
in
pacing?
fact, the left bundle pacing, I think, is highly, highly reliable. The failure rate, now we are doing this regularly from 17 onwards, so it's already 5 years, 6 years plus. So very, very few failures. This, I think, the failure rate may not be more as compared to traditional RBF cycle lead.
Sir, do you need the EP system, or you can just go with the 12 DC only? The idea
Yeah,
is
that's what
that
I
if
was
you're doing
saying
left
that.
bundle area, so
Right.
preferably it should
No,
be done with here.
see the EP lab, if you have and if you have the basic knowledge of EP, I think it is useful. It makes your mind very clear. But if you don't have the EP lab or recording, you can still do connection system pacing. You just need 12 DCG during the procedure. And but don't depend upon the screen QRS complex. You have to record it and check it again yourself, the QRS complex and the LVAT. If your LVATs you can get, I would say below 75 or 78, uh, we are usually very happy. The QRS complex in most of the patients, believe me, it's below 110. It's very common to get actually 84, 85, 78 millisecond also. But at least most majority of the patients, I would say, if your left bundle is recruited properly, selective left bundle pacing, most of the patients, I think QRSs are around 110, 150.
So another question, suppose if you do the left bundle area pacing in a patient with who are candidate for CRT, and if you get the good conduction, especially if you do like 3D mapping, the conduction is normal, and you achieve synchrony what you want, do you still want to put a LV lead?
Very good question. In fact, we even last week, I was doing a case for CRTP. This lady had very bad veins, and I tried in two veins, but the lead was not going. But left bundle alone gave me QRS complex of 112, 115 milliseconds, so I left it there. But yes, there are many patients we have just given dual chamber pacemaker, and the results are very good in these patients. Of course, we need data to follow up of these kind of patients because there is a possibility of distal blocks occurring later on. We don't know. So, if a patient can afford, we still put the left ventricular lead in most of the patients. But for patients who are financially constrained and we get good QRS, we don't care about the left ventricular lead.
Thank you.
Thank you, sir. Next, we pass on to our next lecture.
Thank you very much. Thank you, Jitendra, for inviting me.
Anup, you, Dr. Makkar. Next is on leadless pacing. The current state of art, none other than Dr. Makkar will be presenting his experience in vivo leadless pacing. Dr. Makkar, please.
Thank you, sir. Thank you very much. Good morning, everyone. It was pleasure to listen to my mentor, Dr. Claire. I'll take you to a totally different world of pacing now, the leadless ones. So this is how pacemaker evoluted from a large external pacemaker to a small capsule size intravenous transcatheter pacing system. So this is how the Medtronic Micra looks like, and this is the newest tool in pacing of course, size of a capsule. It can be directly inserted into the RV, work as a single chamber for many years, but now we can do AV sequential pacing also. So no lead related or surgical issues here, and they have reasonable longevity. Like first leadless pacemaker I implanted was 2017, and it is still showing like 6-7 years battery in that, in a dependent patient. So now I can trust on the battery of the Micra. This is how it is inserted. This is how it looks like on X-ray after implantation. So the trial was actually a group of 725 patients, which compared with the historical control group of conventional pacing. So this was a Micra VR trial with single chamber pacing system. The complication rate was less other than the cardiac perforation, which happened in 11 patients, but no death resulted from cardiac perforation. This is still a threat with the Micra implant, but in my clinical practice in last 6-7 years, I have not seen a single perforation if we take proper protocol-based implant. So this is how the implant system looks like. This is the sheath and dilator, and this is the delivery system which goes through the sheath. So this is a 27 French sheath, so it's a creates a large hole in the vein which can be closed by closing devices or by simple pressure or figure of 8 suturing. So little bit about those. This is the delivery system inside the right ventricle, directing towards the septum. So small amount of contrast is given, confirmed in LAO, and nowadays we confirm in left lateral also to avoid the chances of perforation. And this is after we are sure about that this is well abutted with the septum, we release this Micra like this. So and then we do tug test whether the tines are entangled with the endocardium or not. So evolution in India, it started in, what happened? Yeah. So now close to 700 implants have been done throughout all over India of this leadless system. I'm missing a slide here. Yeah, so the conventional indication, so what are the potential indications? So one absolute indication would be bilateral subclavian vein stenosis or bilateral pocket infections, or intolerance to titanium or nickel titanium alloy, which is the metal used for pacemaker, high risk of pneumothorax and other lead and puncture related complications, old and fragile patient not willing for surgery, or high risk of pneumothorax. Then AF with bradycardia, where single chamber pacing now, though there is sequential pacing available. When there is intermittent or rare need of pacing, it can be used as a single chamber pacemaker. Advanced age with limited activity, where you think is high risk for any kind of incision, you can use this. So these were the trial indication. Because it was a single chamber, so large part of it was chronic AF with bradycardia. Then sinus node dysfunction, which is not a good indication for a single chamber, and then AV block in 15%. In my lab, the largest indication is again AF with bradycardia. Second is infection. Now this very rarely it is bilateral infection, but after single infection also, if patient is offered and he doesn't want to take chance again, and is already high risk because of CKD or poor immunity. Like day before yesterday, we implanted a AV sequential micra to a post-renal transplant patient. So because of high dose of steroid and immunosuppression and high creatinine, we offered him and he agreed. Then the other infections, venous access and yeah, so infection and AF, they are the largest indication in our patient. And I prefer this in very old and fragile, like 85 plus 90 years old patient, and they happily agree if they can afford. So there's a few examples which we implanted. 85-year-old gentleman, infected pacemaker lead, VVI. 89-year-old fragile gentleman with left hemiplasia and contracture with small barrel-shaped chest with complete heart block. Bilateral infected pacemaker sites. Then this patient had CABG, AVR, intermittent CHB and CKD with creatinine of 5. 65-year-old lady with bioprosthetic tricuspid valve. Now this is a dubious indication. Conventional lead can be implanted across a tissue valve, tricuspid valve, but I have done 3 of them now through the bioprosthetic tricuspid valve, and it works very well. So our first patient was an 89-year-old gentleman, hemiplegic, bedridden with contractures. He was not able to lie down straight even. Came with CHB, had to put a temporary pacemaker. He appeared to be a VVI candidate just because of no mobility. The life had to continue. So both options were given and we implanted leadless and still doing very well. One unfortunate patient in other center, he was implanted temporary pacemaker waiting for PPI. During PPI he had a severe, probably tension pneumothorax. They avoided PPI at that time and shifted back to ICU. In ICU he had tamponade because of TPI lead. So now, then surgery was done for that tamponade, and then again he was offered pacemaker, so he refused, that old man refused to go to OT again. Mar jaunga, OT mein nahi jaunga. Then we offered leadless, he was convinced and he is still doing very well. So this was a patient where infected lead was there, but pacemaker was removed, lead could not be removed. So there was a sinus already, so we implanted a micra. So he was not ready for the extraction, but when it started having septicemia, then we extracted that lead transfemorally. So you can see the insulation of this lead is breaking. So this was snared through femoral, and I was very skeptical whether it can disturb the position of micra. It was my 3rd or 4th case. Now you can see this, it was pulling the septum and then it went back to its position. So I was reading that once it is entangled inside, it can tolerate up to 10 kg of weight. Even if you apply 10 kg weight, it will not come out of the endocardium. So this is my first case through a tricuspid tissue valve. This lady had, very unfortunate again, lady had undergone MVR in 2004, then tricuspid valve replacement in 2013. There she had CHB, so she was implanted epicardial pacemaker. Epicardial failure happened, so she had repeated syncope, and then nobody put TPI in other city, and then she was shifted to us and leadless was given. So latest example of a teamwork where we had a tower with the pre-diagnosed intermittent CHB and syncope. So previously syncope was totally attributed to severe AS, but when we did Holter, this was RBBB, when we did Holter it was intermittent AV block. So we convinced them and we implanted tower and micra on the same sitting, same table. So it was a good experience, and this can be done, no surgery, not for pacemaker as well as for valve. So this was a good experience. And so this was an AV sequential pacemaker, of course, because she had a marginally low LV, and she is doing pretty well. So we used it as a single chamber for years together when this studies came, and now this is a very interesting concept. Single device inside the right ventricle, but it can provide sequential pacing. How? It can sense atrial mechanical contraction. So the accelerometer on the device, Micra device, senses atrial movements. So there are A1, A2, A3, A4. A4 is the final atrial systole where the active filling of ventricle is done. So it has to sense A4 and then trigger and pace the right ventricle. So I won't go to the detail of this programming here. This is the clinical evidence in favor of AV sequential pacing. So in nutshell, what we realize now is that up to say during rest condition, a rate of 60, 70, 80, AV sequential pacing is almost 100% if atrial contraction is good. And a good surface P wave is also an indicator that patient will have a good sequential pacing. Then echo parameters, if it shows a good EA ratio, then success of AV sequential pacing is good. But on high heart rates, sequential pacing may not be maintained sometime. So this is how it performs. So this is how the programmer looks. Here it doesn't say ASVP, it says AMVP, because this is mechanical contraction of the atria which is sensed. So this all is very interesting, and programming of this is also very interesting, but maybe we can discuss separately. So now the future by another company, Abbott, has come with the dual chamber, real dual chamber implant system. So they have this single chamber system also. The difference is that they have a dedicated retrieval system, and instead of tines they have active fixation screws. So it has not been marketed in India yet, so I have no personal experience, but we are waiting for that. So so there is a docking or retrieval mechanism dedicated to this with a dedicated snare and a helical system for active fixation. And so retrieval of this in long term is also supposed to be better, as we see the difference between tine conventional pacing lead and screwing pacing lead. So in active fixation, it is assumed that the long term retrieval should also be better. Up to 2-3 years retrieval experience has been done already there with this. So it's little bit mapping. So mapping can be done. So without fixing, we can check the threshold and then fix it, which is not the case with the Medtronic system. So obviously with some advantage it will come. So it has to be has to get DCGA approval, and then probably it will come in our hand to. So apart from the single chamber, now they have come with 2 different devices, one smaller one for right atrial appendage and one for the right ventricle. So they will electrically communicate with each other, and beat to beat synchrony can be maintained, and this is upgradable. Like to begin with, you can implant a single chamber, but if you need sequential pacing, you can put another implant in the RA and connect that electronically with the RV device. So this looks very fascinating, and the retrieval system is also there. So this fear always in our mind that if something happens, we can't retrieve. But till now, in my say 55, 56 cases, there is no single retrieval needed for Micra, and there is no dislodgement, no threshold issues. Maybe as the volume increase, we'll definitely feel the warm heat of these complications. So this was also an interesting case where we implanted first Micra AV. 72-year-old gentleman had a pacemaker in May 2014 for CHB, developed CKD in 2015 on maintenance dialysis, unexplained fever, diagnosed as lead-related endocarditis. So we did PET scan, we did everything, transesophageal echo, then conclusion with nuclear medicine specialist or physician, infectious disease specialist. We pointed that this is lead-related endocarditis only, and we just, because the vegetation was very small, so we explanted that transvenously only, no surgery was done. And then after 1 week, we implanted micro AV. So always good to do something first in the area, country, or even in your city. Thank you very much for it.
Thank you, Dr. Mankad, for an excellent overview of this leadless spacing and its newer technologies which are about to come, or hopefully you will be first to use. My question is, how do we know the titanium or this intolerance?
So we don't usually check because this is so rare that there is no allergy checking as such, but repeated implant with, I have not come across also in my clinical practice, but we had discussion in our IHRS group sometime. Maybe Dr. Noob, you remember any case of nitinol allergy or I have not come across, but this is a theoretical indication more than practical one.
Okay.
How do you look for this? Yeah. ASD
devices, okay.
But how do you test for that? How do you look for that? Suppose somebody after pacing, somebody has some suggestive of allergic reactions. How do you confirm it is because of the device?
Yeah, I don't know. I have not come
That is the
across
issue.
this.
That is
Sir?
the issue. He's asking prevalence of bilateral subclavian stenosis because that is one of the indications of what is the prevalence of bilateral subclavian stenosis.
No, very rare, very rare. So I didn't see any subclavian stenosis. Just both side infection.
One question from my side. See, if with TAVI and CHB, you'll prefer to put a conduction system pacing with TAVI or you want to put a micro?
With TAVI. Yeah. Yeah, of course, left bundle pacing can be done. I'm not sure about his bundle pacing. Left bundle pacing can be done with our, and if it is LV dysfunction, conventionally we have done CRT-D also, maybe not immediately, but after say 1 month or so, if LV doesn't improve, I have done 2 or 3 CRT-Ds followed. But same time, yes, if significant LV dysfunction is there, yes, left bundle pacing would be a better idea, yes. But just because of fragility and advanced age, if somebody doesn't want a surgery, so this is a good indication. Because you're doing something transcutaneously, do the other thing also.
Thank you, Dr.
Thank
Mankad,
you,
for
sir.
the nice presentation. And for
Thank
the
you.
next talk, I'll
Thank you.
invite Dr. Anup Gupta for his talk on remote monitoring for pacing and heart failure devices. Dr. Anup Gupta, please.
So, good morning. Thank you very much. So, after 2 talks of implant, so it's like, if suppose you are putting any device, pacemaker, CRT, ICD, it's not like just put a device and forget about it. Follow-up is very, very important. And now the latest thing is remote monitoring for pacing and heart failure devices, particularly like, if you are doing a bigger devices, CRT, CRTD and ICDs. So in those patients, definitely it helps. So what has happened in 2015, it has become a class 1A indication, remote monitoring patient for all CIEDs. And adoption varies from device types. Obviously, like, complex devices, they gain more popularity, ICDs and CRTD, what I said. And the other important thing is CRT in which you think the patient non-responders, those are the patient in which probably if you are doing remote monitoring, you will come to know what exactly is happening. And what it does, it enables early detection for precipitating factor of decompensation, especially atrial fibrillation or loss of CRT pacing, or what are the volume changes. Like, it will give you OptiVol and all the things. So, from remote monitoring, you'll come to know what exactly is happening. So, what are the key points? What are the recent guidelines which has come, like, 2023 ACC/AHA guidelines 2 months back? So, it has been recommended as a standard of care. So, digital health technology, it has become a standard of care. CRT implanted in United States had remote monitoring of almost like 60%. And if you take our country, like, in Asia, it is only 6%. And despite diagnosing the non-response of CRTs and all the thing, there is no change in remote monitoring utilization. That's quite surprising, to be very honest. So barrier to remote monitoring need to be identified to improve the patient care. And it's very, very important to identify the high-risk group so the adoption of the digital health technology in general improves. So I'll show you a couple of cases, like, very interesting, very young 40-year-old man, diabetic, non-ischemic, cardiomyopathy, left bundle, QRS 180, systolic functions 30%. We did a Gallant CRTD implantation. And if you see the post-implant, pretty good parameters, all the thresholds, the P wave, the R wave, the impedance, everything is fine. And the patient was discharged with ongoing bi-week pacing. So what are the transmission findings? So, no alerts, no alerts. So probably the device saying there are no alerts. But if you see the EGM, 30-second live EGM, so what you see is A-sense, V-sense. So why it is A-sense, V-sense? It should be A-sense, bi-week pacing. So it means that there is no ongoing CRT pacing. And when we call the patient back, and what was seen, like, there's a displacement of the atrial leads. So this is very important. You can, as early as, if the patient has got remote monitoring, you can pick up the lead displacement very early. And then what need reposition and ongoing CRT pacing, A-sense, bi-week pacing. So again, the numbers are pretty good. So 99% only LV pacing on the next follow-up, A-sense, V pacing, and the parameters are pretty good. So what it says, like, it's powerfully connected to patient-centric outcome. So why it is powerfully connected? Because Bluetooth-enabled remote monitoring empowers the patient to be powerfully connected. Proactive detection, you can detect all the alerts as early as possible. Early intervention, you can do early intervention, you call the patient back to your clinic and do whatever required. Peace of mind, obviously with constant monitoring of the device, integrity, everything is known. And patient-centric outcome. So that's, again, is very, very important. Second case, 70-year-old man, CABG 2007 with severe LV dysfunction, NYHA class 3, ejection fraction, really poor ejection fraction, LBB, white QRS 160 millisecond, underwent Medtronic MPR CRTD implantation. And the implantation are pretty good. And even if you see the ECG looks very, very nice. And this was like, again, this was like an active fixation lead with a quadripolar Medtronic device because of a very, very huge dilated coronary sinus vein. And then all of a sudden, after a year, patients started worsening of heart failure and then started getting recurrent shock through the device. So with the remote monitoring, because he was from Madhya Pradesh in a small town, Ratlam, so what was happening, it was like, AFib happening and patient was getting inappropriate shock for atrial fibrillation. And because of shock and because of atrial fibrillation, patient was getting decompensated. Correction of atrial fibrillation, manage the atrial fibrillation, get back to the sinus rhythm, and patient improved, symptoms improve. So that's, again, is very, very important. So what the trial has shown, in time trial, it was a implant-based multi-parameter telemonitoring patient, standard care versus home monitoring. Home monitoring, again, it was like multi-parameters, automatic, daily implant-based multi-parameters. What it showed, 30% reduction of worsening of clinical status, 30% reduction. And more than 60% reduction of all-cause mortality. Then again, is significant. Again, the p-value is quite significant. And how it worked, what were the three key elements? Make sure that reliable transmission, at least 80%. So, the whatever the Wi-Fi instrument or your phone connectivity should be very, very good. The transmission should be very, very good. Disease and patient relevant set of rhythm logical and technical parameters. That's very important to be set up. And effective clinical workflow. You know, the moment the data are transmitted, you have to call back to your clinic within 2 working days, rectify the thing, whatever the specific thing, and then improve the patient. So the meta-analysis of 3 monitoring, what the 3 major trials have happened: trust, ECOS, and in time. These are all like, you know, biotronic trials. So all 3 were TrueQuine. And what again it showed, like, you know, if you see this one, home monitoring was assured a significant reduction of clinical relevant endpoints. So if you see all-cause mortality or all-cause mortality with worsening heart failure hospitalization, so relative risk reduction was 38 and 36%, absolute risk reduction was 2% and 5.6%. So that's again quite significant, and particularly these were with ICDs and CRTD patient. So heart failure patient getting ICDs and CRTs with home monitoring, the mortality was significantly low. And again, if you compare the conventional follow-up versus the biotronic home monitoring in all 3, in time, echoed, and pooled, 4.6% absolute reduction of worsening heart failure death or worsening heart failure hospitalized within 1 year. And what were the 3 main parameters? All-cause death of worsening heart failure hospitalization, or worsening heart failure death or worsening heart failure hospitalization. These were p-values of significance. So prevention of heart failure exacerbation was the main driver which was observed in all these 3 trials. Further trials which happened, Optilink studies, REM-HF studies, more KRF studies, again they all favored, like, you know, the remote monitoring was much superior than the conventional thing. So what the latest to 2023, which has come 2 months back, what is the recommendation for remote monitoring? Class 1 indication, in patient with CIEDs, RM is recommended as a part of standard of care should be given to all patients. In patient with CIED on remote monitoring, routine surveillance of lead status and the battery status recommended to ensure device integrity, again class 1. And in patient with device capable of continuous connectivity, the connectivity should be maintained. It should not be like, you know, you get a remote monitoring and just switch it off at your home and don't do anything with that. That is not going to help it. So what are the supporting evidence of standard of care? It reduces the number of healthcare visits, increased follow-up adherence and patient retention. This is very important, early detection of atrial or ventricular arrhythmias. So, you know, you can treat those patients, particularly atrial fibrillation. No data has shown, like, you know, it can reduce appropriate shock. Obviously, when the patient will have VT and all, it should deliver shock. Early detection, quantification of AF episodes, that's important. Continuous connectivity allowed individual patient treatment and continuous updating of therapeutic strategies. Prognosis and outcome, obviously it doesn't prevent disease progression or improve outcome. It still becomes controversial. But early intervention prior to deterioration and hospitalization, if you can pick up the things, like, you know, if you pick up atrial fibrillation, so before the patient deteriorate, or suppose the patient has got a high threshold or lead parameters or a battery deterioration, so you can pick up those things. Automatic multi-parameter monitoring, it is very, very important. This is again consistent with all the pool analysis of 3 trials which I discussed, and it reduces all-cause mortality as well as worsening of heart failure. Cost effective, if you see, probably that is one of the lack of adoption is this, but if you see overall, probably it's a cost effective because you don't have to come to the hospital, don't have to schedule emergency visits and all. You don't have to travel, so you don't have to take off from your office work. The only conflicting thing is impact of remote monitoring on patient acceptance and quality of life. That still don't know, so that's very, very important. Routine surveillance, what you should do, battery depletion, circuit disruption or lead failure, that you should be checked. Early detection of malfunction, if the patient is asymptomatic, before he goes into any catastrophic events, you can rectify that thing. And allow continuous connectivity for pacing threshold and optimizing the battery longevity. Why in our country the lack of adoption? Cost of remote monitoring capable device. If you are talking about pacemakers or ICDs or CRTs, these are more expensive than the basic models. Increased service burden again in hospital because you have to put a lot of staffing for that. No reimbursement. Our healthcare, they don't reimburse for your remote monitoring thing. And this is important, again, lack of physician awareness. Many of the people, they don't know what is remote monitoring and whether this can be done in a smaller town patient with device or not. So logistic, again, staff challenging is definitely challenging obtaining staff, training staff, the burden of the parameters, and then discussing, maintaining a data of the parameters. What is the difference between 2015 and 2023? It's the reverse, 2015 was physician based, now it has more like ancillary staff or the nurse or the technician, they collect all the data and final opinion is given by either it's an advanced physician support or the physician or the electrophysiologist. So what nowadays what we are doing, rather than a site-based remote monitoring where the traditional from home it is conducting, you can do a site-based remote monitoring. Let the patient go to ER, the ER person will transmit to the manufacturing cloud, and then you can decide what are the facilities need to be given. And how it works, acute condition, present to the ER, emergency staff perform the device interrogation, send to the manufacturing, he will analyze and then he will send to the physician and he will pass on the message to the ER that you need to treat it like this. So for this, you have to have a near perfect connectivity and you should have a robust system to ensure connectivity from the manufacturer also, that's very important. And patient compliance should be very good. These are the parameters, if you are talking about ICDs, pacemaker and CRTs, what you should see. For ICDs, all the shock therapies there should be an alert. If the patient is getting more frequently ATPs, there should be alert for that. If the patient has got a pacemaker, what are the burden of atrial fibrillation or atrial tachyarrhythmias, or what is the lead parameters of battery status, that's very important. And for CRTs, you have to see whether the percent of bibeam pacing is more than 99% or not, if there's any loss of bibeam pacing or not, that's very important. So again, red alert and orange alert, same like weather alerts. So red alerts, ICD shocks or low battery, these are red alerts or high or low impedance. The orange alerts, high thresholds or patient getting a lot of ATPs. So this is the drawback, suppose you give a remote monitoring, many of the patients, they start transmitting you probably every day their data. So how to manage those things? So minimizing the alert of non-actionable events. So you know what exactly is happening with the patient, you know the history and you have the parameters, switch off those things. So if you know that this is a known phenomena, so consider switching off that alert. If not, again reassess, and if you think that you want to switch it off, you can switch it off, or you want to keep switch on, switch on. So patient education is important. There should be readiness, and patient education is between physician, the technician, the patient, and the family. So readiness, education, communication, and partnership, that is how it works. So again, it's very, very important. And what is happening nowadays, it's all third-party resources. So manufacturing, so you transmit all the data transfer to the manufacturer service, they will assign to a third party, that will go to the hospital team, and then they will manage. Take-home message is evolving very quickly. Remote monitoring, research study should be performed to determine the optimal models, which all parameters should be given. And the value can be defined in terms of patient satisfaction, cost efficiencies, improved patient outcome. These three things are very, very important. And transition from routine remote monitoring to alert-based, what I said, has become a very high-value visit. I'll stop here, take your question. Thank you very much.
Thank you, Anup, for excellent presentation. Pacemaker can be implanted by anybody, but the troubleshooting and follow-up is very important. You have very nicely explained the role of remote controlling as well, though not easily available into our country because of all logistic problems, but it is the need of these troubleshootings. Any question from the audience?
In long term, you said it's a cost effectiveness, but at the time of implant, was the patient because you have to have additional cost for the device. So what is your opinion about that? How do you convince it?
That is what we are facing right now. Suppose you want to put a pacemaker right now, you can give a home monitoring separately, which is not really costing much, maybe an additional 35,000-40,000 rupees. But if you are giving a Bluetooth, so probably they're spending 1 lakh extra for a pacemaker and probably 1.5 lakh extra for a CRTD and ICD devices. So again, what I said, the last slide, education. You need a very good counseling with the patient and family, and see the patient from where the patient belongs. Suppose a patient is from Ahmedabad, where I am practicing. He lives in Ahmedabad. So probably I will not push him very hard to get a remote monitoring because I know that I can call the patient back maybe very next day or maybe within 48 hours. But if patient from outside, a patient coming from Rajasthan or from Madhya Pradesh, and I know that, these patients are at a remote place. So then I try to educate the patient and family, you should get a remote monitoring so that you can transmit, because then it becomes very cost effective. See, If you tell the patient from Ratlam or from Indore or Bhopal to travel to Ahmedabad every 15 days for his device, so not only say travel expenses, he will miss his office, probably the whole family will be affected. So counseling is most important.
Thank you, for nice presentation. Now we go on to live case box.
I think, Dr. Anoop, the problem with remote monitoring in our setting is not the cost procured by from the patient, but the infrastructure. Because we have a lot of patients on Bluetooth, we have a lot of patients on remote monitoring, but a center who is doing that, they should have their own setup, they should have their own facility to satisfy their patients' needs. Otherwise, this is futile. Because even the depending on industry is not the solution for this. We have to develop, or we are on the way to that, but it will take a lot of time for our setup to do that.
That is what the newer guidelines is also emphasizing, staffing
VLC से कर लो, मुझे VLC आता है.
Can it be shared? I see you set up the. You are in this process of getting the center, but there are so many centers in the city for implanting the devices. Okay. So can you utilize it so that will be easier for everybody?
ये play हो जाएगा इससे. आगे इससे हो जाएगा. Control out. ठीक है, perfect. ठीक है, perfect.
Yes, Dr. Kush and Dr. Makki for.
So thank you so much, sir, and thank you so much for sparing your time in the morning. So we will be present. We have a live case recorded with us of conduction system pacing. So we have total 4 cases. One is lumenless lead with 3830 lead and 3 with stylet driven leads. So the first one is with the lumenless lead. And
I am Dr. Makkar, Head of Department Cardiology of EHCC. With me, we have Dr. Kush Kumar Vagar, our senior consultant and electrophysiology and pacing specialist. So he is the one who is leading our conduction system pacing program. He is a 65-year-old guy who came to us with high degree of AV block, intermittent vancomycin also, but mostly large PR interval and dropping P waves and history of syncope. And we have done the angiogram, that's normal.
yes, sir. So I'll straight away move to the part where we are implanting the lead. So yeah, so we have implanted a His catheter, temporary pacemaker. We try to place the His catheter if we are doing a case in the EP lab, and this is the temporary, but this is not essential to put the His catheter in place, but it definitely gives us some idea where we have to go. Temporary pacemaker, His catheter, we have already taken the 3830 lead inside the 315 His sheath. So now we are maneuvering the sheath and the lead.
So we can imagine an imaginary line from the His bundle electrode towards the RV apex. So that's a straight line. So yeah, so you can see that it is like 2 to 3 centimeter below the His electrode. And if you draw a line from tip of the His electrode to the RV apex, so it will touch that line in upper half, mostly in the upper half or upper 1/3. Basic idea is to reach to the basal septum toward the RV side. Okay. Now we have sheath which.
So as mentioned that this is the LO view, LO30 view, and this sheath should be as perpendicular to the septum as possible so that our lead goes inside the septum very easily. So this is very important to keep the sheath as perpendicular to the septum, which is in our case, it's very perpendicular.
The RV septum, and we have lead inside, and the tip is touching the RV septum, and we are pacing the RV septum now. So basically, what we are trying to do right now is trying to find out the right place where to penetrate the septum and try to go toward the left side. So when we are pacing the right side of the septum, you see lead V1 first, which has a notch. Yeah, it's a kind of W pattern.
Sweep speed to start. Sweep speed. Increase the sweep speed. So we have, as sir was mentioning, we have so basically we are on the right side of the septum, and now we have to see whether this is an ideal site for penetrating the lead deep inside the septum or not. So which we can see with the help of the pacing morphology in the ECG, in the 12 lead ECG. We can see the negative notch present in the lead V1, AVR, AVL discordance, and lead 2-3 discordance. So this means probably you are at the right side, and you can screw it here, go inside, deep inside the septum. 150.
Yeah.
So we can clearly see a
Yeah.
notch.
So very good notch in the V1, a negative V1 of course, LVVB type, because we are pacing on the.
Yes, sir was, as sir was mentioning, 2-3 discordance, AVR, AVL discordance, and lead V1 is negative. As Dr. Dajit was telling yesterday, that lead 3 should be negative, lead 2 positive, AVR negative, AVL positive, and preferably if you have a notch in the lead V1, then it's
The right side, and then there is a notch there, and there is AVR, AVL discordance, like AVR is negative, AVL is positive. Similarly, 2-3 discordance is not there.
lead 2 is positive, lead 3 is also
lead 2
negative.
is positive, lead 3 is negative. So lead 2 and 3 discordance, lead AVR and AVL discordance, a notch or W pattern in V1 suggests that we are on the right area, on the right side of septum. So now he will rotate the lead and try to penetrate the septum with this lead. So there are clockwise rotation given slowly one by one. You can, and this is generally we do in LAO thing, LAO view, and now you can watch Dr. Kush's hands. He's moving the lead clockwise. Mega. So what you will see is that this lead will slowly come out of the sheath and will penetrate into the right side of the septum.
The notch has started moving up, sir.
Yeah.
So initially we saw that there was notch in the descending limb of the QRS in lead V1. Now we can see that as we have screwed inside the septum, the notch is started moving up. You know, now it has come, the notch is present in the ascending limb of the QRS in lead V1.
What we see is that we can see an R wave now, because that notch is going upward and taking a shape of R wave.
So that means we need to screw more.
Yeah.
And the
But
evidence
there
is
is still not the right bundle branch morphology is not there.
Yeah. So it gives us confidence that yes, we are going in the right track, and also we have to screw more. So as we screwed more, so
Initiation of pacing stimulus to the peak of R wave. It is typically said that if it is less than 80, then you are capturing the left bundle branch.
so as we screwed deep, we can see that the notch has still moved up in lead V1, but still I think we need to screw more. So, and also the LVAT was a little bit on the higher side, so we screwed more. And
If we are selectively pacing the left bundle, then there will be an isoelectric baseline between the pacing stimulus and the QRS of
how much is the impedance?
paced. So what you can clearly see is,
So we have given the sheath angiogram as well. It's not necessary to give the sheath angiogram, but yes, we gave in our case. And so basically, we know how the length of the screw, this portion and the anode, and by the help of that, we can assess how deep we are inside the septum.
RV, the sheath is touching the septum, contrast is spreading in the RV, but that lead is much inside the septum and touching the left side of the septum. So what we have got till now is that we have penetrated the septum, the cathode has gone towards the LV side of the septum, and the pacing parameters from which we are getting from there is a narrow QRS.
We can see a terminal RA very good. Yeah, so I think we screwed more, and on screwing, we can see that we got more R wave in lead V1. So I think terminal R wave in lead V1, fixed LVAT.
In the right atrial lead.
Yeah,
and
now
after
here you
that
can see.
the atrial lead
So after that, I screwed more, and after that, we can see that we are getting a more terminal R wave in lead V1. And the LVAT was also constant at this time. It was fixed at high output and low output. So based on that, we took a decision to not screw further, since it was already, the impedance was falling, and we were far inside the septum. So after this, we just slit the sheath, and I think I can show the,
Right location, and
this is the
then there are
final,
notes.
just a moment.
This is one
Yeah.
of the best slitter which Medtronic makes. Is really comfortable.
So this is how we slit the
Holds
lead.
I hope all.
So it's
So
all,
if you can see the hand movement here. So you have to keep your right hand stable because it is holding the lead, and you have to pull the sheath. So it slits the sheath. This is how it is slitted. If you stop in between, then it is difficult to capture it again. So that has been done beautifully. The sheath has come out, and like any other lead, now we'll stitch that. So we can show the final position here in RO and LO about the left bundle
so
lead,
this is RO, and
then we can close the case.
this is an LO.
Yeah, now you see this is the LO, so it is pointing towards septum. It's just below the his bundle electrodes where they are placed.
So this was the case with the lumenless lead, and I have three cases. One we did with the Biotronic system, which is the stylet-driven lead. I managed, no worries. So as ma'am was mentioning yesterday, Daljit ma'am, about this Biotronic system, so she had explained beautifully about the sheath and the lead and the technique to how to implant this lead for the left bundle or the his bundle location. So usually we go for the left bundle position with this sheath only, and the lead is the Solia S lead, and the catheter is the Selectra 3D catheter. And as far as history is concerned, she was a patient who had been implanted a pacemaker, and then she developed pacemaker-induced cardiomyopathy. Ejection fraction was 40-45%, and complaining of dyspnea on exertion. So this is the catheter with three-dimensional curve, and this is the Solia S lead. So the beautiful aspect of this sheath is that there are a lot of shapes available for this sheath, and at different length. So you can choose the length and the shape according to the RA-RV size. So this is actually helpful if we use this system, that we can choose any sheath size and length. So it has got 3 curves and 3 lengths which are available, which makes the combination of total 9 combinations which are available. And this is the lead. So this we can see the screw. So this is different from the Medtronic system. So in this, this is not a lumenless lead. This is the conventional RV lead which we implant for the normal pacemaker, and with the help of stylet. This is stylet-driven lead, and so this was the baseline ECG. Again, we placed his catheter, and his catheter was already in place. She was implanted a single-chamber pacemaker, I think, earlier, and the TPI is in place. So the same technique as we discussed earlier over the long wire. We took the sheath, clockwise movement, enter in the RV, and then took the lead. I think how to prepare the lead, ma'am has shown beautifully yesterday. So the screw is already out. Now we have to just rotate the lead as a whole, and the one thing which is again very helpful with the stylet-driven lead is that you can connect the cable on the stylet itself, and while rotating we can see the change in the morphology of the ECG, which helps us in telling us how deep we have to go when we can stop, as compared to the Medtronic system, where we have to again disconnect the connector and then again connect it to the cathode. So I think this was same case, same technique, everything was same, and we just screwed the lead deep inside the septum. I think this is, we are screwing the lead inside the septum, and how we screw, just same technique for screwing, and this is, we gave the contrast, and we can see how deep this lead is inside the septum. So this is the, this is not the 3830 lead, this is the salad-driven Patronic Solier S lead with this Selectra 3D catheter, and we got a terminal R wave with a good LV activation time of 51 milliseconds, and yes, we have to adjust the loop before slitting. And just remove the sheath, and this is the final position in RAO and LAO, and this is the after the final programming, the final QRS. So I'll show two more cases in short. One is the with the Abbott system. So this is also a very nice catheter, and we use this catheter predominantly for his bundle pacing, because of the problem is that it doesn't have a secondary curve, so it's very difficult to place the catheter below the his region, below the his towards the RV septum. So we have to make a secondary curve if we want to do a left bundle pacing with the Agilis His Pro. We can do that. It's not very difficult, but needs a little bit of practice. So this was the patient. I think patient was of 6 Hannah syndrome, and he had a history of syncope, and so this is basically the catheter. Again, the lead is same we use for the conventional pacemaker. The RV lead is the same, but just the catheter is different. Deflectable catheter, and the best part is that again we don't need a lead to map the septum. The distal part of the catheter has electrodes. We can just do the mapping with the help of this catheter. There is no need to even take the lead. So this catheter will, we can connect it with the EP system, and it can very easily give us the signal whether we are at the his position or not. Again, his is in place. Since I think it was 6 Hannah syndrome, we didn't put a temporary pacemaker. 2 punctures, the sheath is in place, and yes, the sheath is in place. So we planned for his bundle pacing in this patient, and this was the signal in the Agilis His Pro. So this is the catheter signal. So this is not the lead signal. So our lead is still probably inside the sheath, or maybe I have not taken the lead, I don't remember, but this is the signal in the Agilis His Pro sheath. We can see a beautiful His in this catheter. So that means we are at the His position. We can take the lead now, took the lead, placed the lead at that position. We can see again a beautiful His signal in the lead with a large V as compared to A. So always try to place, if you are going for a His bundle pacing, try to pace the distal His as far as possible. So this was the signal, intracardiac His signal, and this was the lead positioning. We, after lead positioning, check the parameters, and then I think we just removed the sheath, and this was the ECG at 1.5 volt, very narrow QRS. And as we decrease the output, and at 1 volt, we can see it's still pacing. It's a paced QRS, but then his bundle capture is lost, and this is probably RV septal capture. We can see a notch present in the QRS as compared to this, in which there is no notch. So probably from his bundle capture, it's the RV septal capture. So this is the final position of the lead in the X-ray and in the fluoro image. So in short, I'll just discuss one more case. We can do left bundle pacing also with Abbott system, just we have to make a secondary curve. So recently Boston has also came up with this conduction in the pacing catheter. It is called as SSP catheters. And again, one more, it has got a different shape, SSPC 1, 2 and 3. Mostly we use 2 and 3 if we are planning for left bundle. SSPC 1 if we are going for left his bundle. And again, this is the only company which is giving the catheter for the right side of. If we are going for a right side implant, then we can take SSPC 4 sheath. So similar, the lead is same. Again, it has got 2 leads. So as Dajit ma'am was telling yesterday about the second lead, which is the lumenless lead, that screw, that the tip doesn't pace as compared with the Medtronic system, where there is spacing with the tip also, but with the Boston lead, which is a lumenless lead, the tip doesn't pace. So that is why mostly we have used the conventional RV lead in this, if we are using the Boston system. And according to the shape and size of the heart, we can plan whether we have to use SSPC 1, 2 or 3. And again, this is the sheath, same as the Biotronic system. The technique is same. We have to, so this was a patient, DCMP, left bundle branch block, LV dysfunction, normal angiogram, so planned for a CRT. So it's planned for CRT-P since he was not affordable, and since angiogram was normal, planned to just give a P function, not a D function. So this was the CS lead, the quadripolar CS lead, a QT expert spiral lead, and then we took the sheath, his catheter TPI is in place, took the sheath, this is the lead, this is the Ingenuity Plus lead, and I think, I'm giving contrast here, so we can see here is the contrast from the sheath and how deep the lead is inside the septum towards the left bundle area. So this is basically a lot CRT-P, which we are doing. So basically, so we feel that if we are going for a CRT-P, then when we have to go for a placing a RV lead, then why not place a left bundle lead, which will further narrow down the QRS. So this is the final position of the lead, of the LV lead, the left bundle lead, the RA lead. This is the final position, the left bundle lead, LV lead, and the RA lead, and this is the 12 lead ECG, pre and post implant. Thank you so much. So in short, I have discussed about all the 4 systems, sir.
Thank you, Team Makkad, for the excellent presentation of all 4 varieties, the newer technologies in the electrophysiology system and pacing system.
One question is that we are using CRTD.
CRTD.
And physiological pacing, that is his
yes, sir.
bundle pacing.
Yes, sir.
So how you, what's your status regarding the superiority or non-superiority of his bundle pacing and CRTD in view of heart failure?
So basically, so you mean to say that you are planning a CRTD and
heart failure, that is risk.
Yes, sir. LV dysfunction patient, you want to plan a CRTD. So we have to place one RA lead, one RV defib lead, and one LV lead in the posterolateral vein of the coronary sinus. But you don't want to do this. You want to go for a his bundle or a left bundle CRT. So again, there are 2 ways you can plan this case. So either we have to place the RV lead, we have to place the RA lead. Now, instead of putting a LV lead in the coronary sinus, in the posterolateral vein, what you can do, you can place the, instead of the LV lead, you can place the his bundle lead or the left bundle lead, which will be called as the his CRT or a left bundle CRT. But then the problem is, sir, you are not placing a lead in the posterolateral vein. So you're just relying on the his bundle and the left bundle lead. For the whole purpose, you want to give a heart failure treatment for this patient. And you are just relying on that left bundle or the his bundle lead. And if you don't get a very good parameter, suppose on table, you're not getting a very good QRS by this his bundle and the left bundle lead, and the whole value of using a CRT is lost in this patient. So that is why what we do, if we are planning a left bundle or a his bundle CRT, we actually plan a hot CRT or a lot CRT. So in that case, we use 4 leads. So for a CRTD, so RA lead, RV defib lead, one lead in the posterolateral vein in the coronary sinus, and the 4th lead is our left bundle lead. So for this, you can place, we use 4 leads, and we use a DF1 system, and with the help of DF1 system, we can connect these 4 leads in the device, and then we get actually a better QRS as compared to either a plain CRT or a his bundle or a left bundle CRT. And especially if a patient is of a ischemic cardiomyopathy patient or a IVCD patient, then this is actually recommended to, consensus recommendation to use 4 leads rather than 3 leads. But purely his CRT or left bundle CRT, we are actually not doing pure his CRT or pure left bundle CRT. We are using 4 leads or a conventional CRT. I think all our senior colleagues are, sir, Makkad sir is there, everyone is there, sir. They are better person to, answer this question.
Yeah, so probably your question was comparing these 2 technologies for heart failure patients. So I think We are at a stage where we have to go with conventional CRT in a given indication, and we can't use right now the left bundle or his bundle pacing as a replacement for CRT till more data and guidelines come. So, but yes, in some very sick atypical populations like not typical left bundle branch block, IVCD, very wide QRS, then in those cases, as he said, left bundle optimized or his optimized CRT can be a good idea, but not a large chunk of evidence is there in favor of that. So we have done around 10, 12 cases of left bundle optimized and I think 2 cases of his bundle optimized CRTs. Let's see how they do. Yeah. But conventional CRT, we go for conventional CRT. But we are doing I was asking Daljit also, most of the centers are going for CSP in all dual chamber, most dual chamber pacemakers, but we are reserving this for borderline LV functions or very high dependency on pacing, and where patient is likely to develop cardiomyopathy. But we are doing like only 20% of our dual chamber would be CSP in comparison to other centers where we are doing 80-90%. So we are still sticking to the guidelines of already existing LV dysfunction or borderline LV dysfunction where CRT is not indicated, or purely pacemaker induced cardiomyopathy, or left bundle branch induced cardiomyopathy. That is also very underdiagnosed phenomena. We have seen patients who have left bundle and after 5 years they will come back with LV dysfunction. So these are probably the patient who can be purely benefited by left bundle pacing. Yeah.
So that was my question. So the borderline patient who is not having any CRT indication, EF is 45%, but he requires pacemaker. What should be the choice? Yeah. And secondly, you don't know rates. Sometimes the patient may develop rate-related LBB also that you don't know at the time of at resting. There may be not be the LBB, the conduction will be normal. But suppose on exercise, walking, the patient develop wide QRS. No, resting is not regular, it's incomplete LBB, but rate-related, they may develop rate-related LBB. And they have borderline LV function 45% and they require a pacemaker. So what should be done for these?
You can consider LBBB. I think it's a gray area and it depends upon at what rate you are developing LBBB. Because you can run the patient on treadmill. Because few patients I've seen 80, 90 heart rate, they develop LBBB. Few patients, they develop LBBB at 150, 160, 170 heart rate. So I think each patient is different. My point here is, whenever we are adapting any comparatively new technology, we should be knowing in whom we should not be doing it, more than in whom we should be doing it. So I feel any patient who's having a myocardial disease for that matter, for example, ischemic cardiomyopathy, LBBB, anti-wall MI, severe LV dysfunction, there's a big scar. So patient needs bi-V pacing. It's not only narrowing of the QRS. Any patient who's having intraventricular conduction delay kind of left bundle branch block where you know it's a myocardial disease, it's better not to go for conduction system pacing. Patient is having hypertrophic cardiomyopathy, you know it's a myocardial disarray. I don't think you should do because the septum is very diseased septum. However, it's a very thick and big septum, but it's a diseased septum. You should not be doing conduction system pacing. So only if there is a typical LBBB, there is no scar, you know, if you have done an MRI, or at least with your maximum capacity, you have seen that there is no evidence of scar. It's more of an electrical abnormality. Those cases, I think, would be better to choose.
Slightly I differ here. In ischemic we are doing, but yes, not purely left bundle. We are doing load CRTs. Just we want to explore this possibility, whether it helps or not. It is arguable, but yes, not pure left bundle pacing, but in ischemic cardiomyopathy, necrosed septum, we have tried to do load CRT.
Rate-related LBBB and EF is around 45, but the patient doesn't have any other symptoms. I think probably you could still wait and watch rather than intervene. No, but is it rate-related LBBB or? So if you are talking about AV block, yes, then all these options are there. But if it's 6 sinus, then
I think this is the textbook, this is the guideline indication for left bundle pacing or his bundle pacing, where 45% EF is there, conventional CRT is not indicated, Brady indication for pacemaker is there, so he probably the best candidate for left bundle pacing.
Thank you, Ghosh. Thank you.
Sir. Thank you so much, sir. So I think, sir, we can have a tea break, or we need to continue with the session?
I think we can continue. We are
Okay.
a little bit
Okay,
late,
no issues.
but we can take our cup of tea or
Sure, sir.
coffee
Sure.
and come back.
So we should invite the panelists, sir, or for the next session?
Yes.
Okay, sir. So the next session is the Sudden Cardiac Arrest Symposium. And for that, I would like to invite Dr. Anshul Gupta, Dr. C.B. Meena, sir, Dr. Deepak Maheshwari, sir, Dr. Devendra Shimal, sir, Dr. Dhananjay Singh Sekhabhat, Dr. Jugal Kishore, Dr. O.P. Khoja, Dr. Pradeep Singhal, Dr. Sunil Jain, Dr. B.B. Agarwal, sir, and Dr. Sunil Beniwal, sir. So please come, sir. Dr. C.B. Meena, sir. And the talk will be given by none other than Dr. Ajay Nayak, sir. And the topic is primary prevention for sudden cardiac death, the ICD before VT. A very important topic, I believe.
good morning, everyone. This actually shows documentary evidence of what happens in sudden cardiac death. Patient here in the first couple of beats is in sinus rhythm, and then there are PVCs, patient gets ventricular tachycardia, it degenerates to ventricular fibrillation, and within 10 minutes, the story is over with asystole. And of sudden cardiac deaths, almost 2/3 are due to ventricular tachycardia. Primary VF occurs in about 8% of patients. Torsades in another 13% of patients. So the majority of sudden deaths are due to ventricular tachyarrhythmias. Oops, what's happening here? Okay. And when you look at the etiology of these fatal arrhythmias, 80% it's going to be cardiomyopathy, coronary artery disease, and another 15% cardiomyopathy. So it's structural heart disease which is responsible for this. So when you look at risk factors for sudden cardiac death, survivors of sudden death, survivors after ventricular fibrillation, these are at highest risk. Prior episode of VT, previous myocardial infarction with LV dysfunction, low ejection fraction, dilated cardiomyopathy, LV dysfunction, heart failure, all these patients are at high risk. Family history of sudden cardiac death, patients with HCM, long QT syndrome, other cases like congenital catecholaminergic polymorphic VT, ARVD, or Brugada syndrome, all these patients are at high risk. The problem is here. The highest risk factors for sudden death are those patients who had an episode, like a sudden death survivor who survived a VF or a rapid VT, has been revived with CPR, VT with syncope, or VT in presence of LV dysfunction, or patient with VT with symptoms. So, but the numbers, the risk here is highest, but the numbers here are less. The problem is patients who have previous MI, maybe having NSVT, LV dysfunction, the risk here is lower compared to this subset, but the number here is huge, and we need to deal with these patients in our clinical practice a lot. So population at risk for sudden death in LV dysfunction, EF 35% or less, NYHA class 2 or 3, we would probably give something like amiodarone to reduce the risk if these patients have PVCs and all. Problem is, like it was shown in the Marriott and CAMIAT studies, that whether you give amiodarone or whether you just treat with a placebo, amiodarone, the level of protection is just like a placebo. So the amiodarone doesn't protect against sudden cardiac death. The risk of sudden death in post-MI, low EF patient, it's around 10 to 15% sudden death, and total mortality is approximately 25 to 30%. So it's a huge problem that we are dealing with. It's a huge population, so we need to identify the patients who are at highest risk. Patients can be evaluated for risk factors before they experience sudden cardiac death. So this is primary prophylaxis. Patient has not had an episode of VT or VF, has not survived an arrest, is relatively asymptomatic. But we have to protect them against potential sudden death because the first episode could be fatal. And they can be referred for treatment options available for prevention. The principal roadblock for defibrillator implants remains our perception that defibrillator benefit is modest for the large proportion of primary prevention patients. That is, we see a lot of patients moving around who have had an MI in the past and are relatively asymptomatic and they are doing well. So giving a defibrillator to these patients, to us as clinicians, we feel it is an overkill. But the data shows that these are the patients that you need to protect. So is there a better way to understand about higher risk patients? Can we risk stratify these patients better? The current guidelines are this. In patients with EF, this is for ischemic heart disease, coronary artery disease patients, primary prevention. Remember, these patients have not had episode of VT-VF or have not had a sudden cardiac arrest episode. So this is primary prevention in ischemic heart disease. EF 35% or less, at least 40 days post-MI, at least 90 days post-revascularization. NYHA class 2 or 3, despite guideline-directed medical therapy, they have to be on optimal medication. So here ICD becomes class 1A indication. And if it's a post-MI patient, NYHA class 1, even EF of 30 or less, it becomes class 1A indication for ICD. And how do we do that? Transvenous ICD currently is the way to do it. That is how it should be done. When you come to next subset of patients, post-MI patient, EF 40% or less, non-sustained VT has been documented, and on EP study has VT-VF, again becomes a class 1 indication for defibrillator. So successively we are going at a next population and a huger population of patients. Even if it's an NYHA class 4 patient, if the patient is going for a cardiac transplant or is a LVAD candidate, you should protect with a defibrillator. But if it's a disease which is too far gone, class 4, no prospect of transplant, etc., these patients, there is no point giving a defibrillator. Now these are studies which have, these are landmark trials. You've heard about these in lectures for a long time. The dark blue circles, these were AVID, CASH and SIDS for secondary prevention, where the patient has had VT-VF, is a survivor of sudden cardiac arrest. No question, giving defibrillator to them was very effective. The light blue color are patients for primary prophylaxis, and these are MADIT, MUST, MADIT-2 trial. The outcomes of these prompted putting those guidelines which I just talked about. So ICD indication for these patients for primary prophylaxis. And the last huge trial was SCUD-HEF trial. This was back in 2005-06. So survival benefit has been demonstrated for patients who have survived a cardiac arrest, so this is secondary prophylaxis, who have sustained VT not attributable to transient reversible cause, and LV dysfunction, ischemic, non-ischemic cardiomyopathy. But our medical therapy has now evolved, and that is what we all have seen. Patients are getting ARNI, SGLT2 inhibitors, our medications have improved so much that we see less number of patients who are having this. And there was a study called DANISH, which came in 2015-16, where the benefit was not greatly seen. So there was some question regarding defibrillator protection for primary prophylaxis. Now we have two huge studies, SWID-HF and UCRTD, UCERT-ICD, which gives us a little more information about this. SWID-HF analysis came in 2019. So in current patient treatment with optimal medications, also when ICD was given, the all-cause mortality was less compared to matched controls. So even in current era, with the best medication, ICD gives better protection. Primary prevention ICD was associated with 27% reduction in all-cause mortality risk at 1 year and 12% reduction in all-cause mortality at 5 years. So ICD provides incremental benefit, incremental protection. Same was seen in the EU CERT ICD trial. Again, the all-cause mortality in ICD group was, the probability of survival was better in ICD group compared to control group, and ICD group sudden cardiac death, the cumulative incidence of all events was less in ICD group. 27% reduction in all-cause mortality risk at 4.8 years and 83% reduction in sudden cardiac death. So even in current era, with the best medication, ICD provides incremental benefit. With the better medications also, and this was Paradigm HF trial, ARNI trial, when you look at cardiovascular mortality, this was showing with ARNI 20% relative risk reduction from 16% to 13% cardiovascular mortality. But when you split this population into patients who had ICDs versus no ICDs. So this is these are patients without ICDs. Mortality was 17% with enalapril, 13% with ARNI. And when you took the ICD population in this group, the mortality in the was 13% in the enalapril group and around 10.8% in the ARNI group. So over and above ARNI, ICD continue to provide better protection. Question was about the Danish results, which came in 2017. This population, it was found, had unusually low risk of sudden cardiac death. So this was where it was in the graph compared to the highest, from higher to lower risk, and unusually low sudden cardiac death rate, 1.5% per year. So in these patients, there was really not much data which came out of in terms of ICD protection. But it was when further sub-analyzed, when they looked at patients who were less than 70 years of age. So for them, a relatively younger population, all-cause mortality was lesser in patients with ICD, and compared to those above 70 years of age, there was no additive benefit of ICD. So in younger patients, ICD did provide protection. So we saw the initial trials for secondary and primary prevention. We saw the Danish trial, we looked at the SWID-HF, EU CERT ICD data, and in real life, this is Medicare data, huge number of population, huge number of patients, MADIT2-like patients, SCUD-HF-like patients. It was seen that Medicare beneficiaries with EF 30 to 35% hospitalized for heart failure had better 3-year survival with ICD. So even in real life, the defibrillator provided better protection. So the contemporary research supports the old landmark trials. Even with improved medical therapy, ARNI, SGLT2, ICDs continue to show benefit. And neutral Danish ICD data for younger patients, ICDs was still provided protection. For our huge population, we have 140 crore people. We have a huge population with coronary artery disease, post-MI patients. Can we provide any additional risk stratifiers? So these are some things which we have looked at. Patients who have low EF, those with the least EF, 15 to 30%, highest risk of sudden cardiac arrest. So we need to look at these patients a little more closely. Maximum rate of arrhythmic deaths occur between 16 to 30% EF. So these are the patients who should need to be protected. So this is the population less than 30%, higher risk of sudden cardiac death. But note that even patients with EF more than 30% formed a good number of population who are at risk of sudden cardiac death. So don't forget that population. Apart from low EF, patients who had syncope, just a couple of minutes more. Patients who have had syncope in presence of LV dysfunction. These are patients probably at highest risk, and these patients should be considered having a secondary prevention indication for ICD therapy. Patients who are having NSVTs, PVCs, those who have the highest such ectopy in presence of LV dysfunction, these are at highest risk. So these patients need to be protected. Patients who have LV dysfunction, wide QRS, those with the widest QRS had the highest mortality. So these patients need to be protected. And this is from MADIT-2 trial, which was almost 2 decades now. Time after MI, the longer the patient has had remoteness of MI, 10, 15 years in the past, the higher chances that the patient will have mortality due to sudden death. So sudden cardiac risk and ICD therapy in remote MI, these patients need to be protected. So with advances in ICD therapy, the common misconceptions, ICDs are too expensive. That's not applicable anymore. In fact, in a lot of our Prime Minister schemes, ICDs are included. The shock burden is too high. All that is for the past. ICD prices have steadily declined. They are covered in schemes in our country. Many VTs do not require a shock. They can be treated with anti-tachy pacing. And anti-tachy pacing is now become so refined that patients don't even feel anything. It has dramatic reduction in the number of shocks. So defibrillator technology has evolved. This was 30, 40 years ago, where patient had epicardial surgical patches and defibrillator was a huge box implanted in the rectus sheath. Then came sub-Q arrays, and then came transvenous ICDs, which are we still doing, and subacute ICD, which Dr. Saxena will talk about. This is how it has evolved. Thank you.
Thank you, Dr. Ajay, for a wonderful presentation. And this is a big problem, especially in the younger population. And most post-MI patients, they are usually unprotected and they die suddenly.
Yes.
And as you said, so I would just like to have some idea about that we have discussed one and a half protection. So what can you say about it? Because all of them should be aware of it.
Yeah. So absolutely, what sir is talking about is 1.5 protection. When we talk about secondary prevention, that is the patients who've already had VTVF, have had secondary, have survived sudden cardiac arrest. So that is secondary protection, if you call that 2. And primary prevention is our post-MI patients, LV dysfunction, who've not had any VT episodes. If you call them 1, then we need 2 is a limited number of patients, 1 is a huge number. So if we risk stratify it better, we try to get that 1.5 patients who are at slightly higher risk. If you can identify those patients, those would really be benefited the most by defibrillator. And in those 1.5, these are the 4 things we talked about. Patients who have had syncope, or patients who have NSVT, PVCs on their Holter, patient who have wide QRS, and those patients who have the lowest of EF. So these 4 important points should be considered, and they can be taken into, called as 1.5 prevention. We did this study, and it was published, and it was very well appreciated, especially for this part of the world, where penetration of defibrillators and economics matter a lot.
Second thing you said, like we have all these schemes now, in Rajasthan is fully covered, insured. So are we justified to give ICD to all the patients who basically qualify for the primary prevention? Ideally, if you look at the guidelines, I think everybody should.
Yeah, as per if you go by the guidelines, yes, we should inform them at least, and wherever possible, we have to protect these patients. Definitely.
Sir, I want to put a scenario in front of you. Patients with entry-level MI, and we dispatch him, and then he developed the complete heart block next day. And as we know that entry-level MI with complete heart block, there is a large myocardium is on stake, and probably his EF is going to be remain low. So as per guideline, we have to wait for the 40 days post-MI or 90 days post-revocation. So at these particular patients, should you put a pacemaker, or you straight away directly wanted to go for the IICD?
So this is a very special category. Patient has developed AV block, has a large myocardial damage, The prognosis of this patient depends not only on the conduction problem, but also overall the pump function. Here you need to give this patient pacemaker, and the patient is going to have LV dysfunction. It is better to give this patient a defibrillator rather than a pacemaker alone. The defibrillator 40 days or 90 days, that is for primary prophylaxis, different category of patients where they don't have conduction problem. Here you need to put in some kind of a device to give pacing. So you might as well give the patient a defibrillator. Also think of CRT if applicable for this patient.
Any questions from the audience? So if there are none, thank you, Dr.
Thank
Ajay,
you.
for the wonderful presentation, and I request. So next talk is online. Okay. So Dr. Anil Saxena is ready. Okay. Welcome, sir.
Yeah. Hi.
Yeah. So
Good
Dr.
afternoon.
Anil Saxena will be delivering a talk on subcutaneous ICD, and you're welcome, sir, and please.
Thank you. Thank you so much.
Thank you very much.
And let me share my slides. Good morning, everybody. It's indeed a pleasure to join from Delhi. I wish I was there. For some personal reason, I could not come, but I am certain I'm missing a lot of fun there. So my task is to talk about subcutaneous ICD for next 14-15 minutes. I really enjoyed the talk given by Dr. Ajay Nayak, and ICDs have really changed the management of patients who are vulnerable for sudden cardiac death, because by constantly monitoring the heart rhythm, by looking at any dangerous arrhythmia, they can promptly intervene and save life at the critical moment. Now, there are certain problems also with the ICD, and most of them are related to the fact that we have to implant a lead inside the vascular system. So whether it is acute complications like hemopericardium, pneumothorax, or chronic complications like lead failure, lead endocarditis, venous occlusion, and issues with the lead extraction, etc. We know that about 10 to 20% patients may have some lead-related complication by 10 years. And in fact, this slide shows very clearly, so many studies have shown that the lead failure rate is around 10 to 20% by 10 years. And this includes patients who have a change in impedance or high threshold, etc. But the lead failure rate is significant. So for last many years, it has been in the works to have a shock box kind of ICD where we don't place it inside the vascular system, but just outside the thoracic cage in the subcutaneous space. And the work started in about 2000, in the early part of this century, and 2012 became a reality when the first study was published by Dr. Bardi et al. And this ICD has a lead which is entirely subcutaneous, and the device, of course, is subcutaneous. So the lead is tunneled along the subcostal margin, and the defib coil is placed in the parasternal zone. And there are two sensing electrodes on either side of the coil. And together with the can, they form three vectors, as we can see in the right panel. So we have a primary vector, secondary vector, and alternate vector, and they provide the assessment of heart rhythm and lead to diagnosis of arrhythmias and shock. The potential advantages are that there is no need of any venous access, so it can be used in patients where venous access is not available or there is bilateral pocket infection. It avoids lead endocarditis. It avoids problems associated with the lead extraction. Those of us who perform lead extraction know how complicated it is and how risky for the patient it is, besides being very expensive. It's quite suited for children compared with transvenous ICD because we need to preserve the subclavian and innominate vein structure for as long as we can. And it also preserves the site for transvenous ICD subsequently if it is, and it's very important for younger individuals. The potential disadvantages are that there is no bradycardia support at the moment. There is no ATP available, and it cannot be upgraded to CRTD. So that is the problem, which are of course being overcome now. Now the device looks at the surface ECG instead of intracardiac ECG, and after passing through several filters and algorithms, it diagnoses the arrhythmia, and once it is certain that the patient is having a ventricular tachycardia or fibrillation, it delivers a 80 joule shock. And this is non-programmable shock. So there are limitations in the programming, but it is equally effective as far as the termination of arrhythmias is concerned. This was the early study which led to the approval of this device. We showed that 98.2% episodes were terminated within the available shocks. The estimated 3-year inappropriate shock rate was high at 13%. At that time, it was high, but now, of course, with the improved algorithms, it has become comparable to transvenous ICD, as I will come subsequently. Now, the main advantage of subcutaneous ICD lies in the fact that the lead-related complications are very less, as we can see in this large meta-analysis, that SICD led to only 0.14% of lead complications compared to more than 1% of the transvenous, so about 80-90% reduction in the transvenous lead complications. The inappropriate shock rate is quite similar, but there is a difference in how they differ, in the sense that SICD, most of them were related to T-wave oversensing. It is very good at arrhythmia discrimination as far as differentiating SVT from VT is concerned. The transvenous ICD, on the other hand, doesn't lead to much T-wave oversensing, but it is weak as in differentiating between SVT and VT. So both have their own strengths. This Praetorian trial was one of the first, it was probably the first head-to-head comparison between transvenous and subcutaneous ICD, where the primary endpoint was complications plus inappropriate shock, and the secondary endpoints were device-related complications, related complications, inappropriate shocks, and mortality. And what it found was that the overall primary endpoint was quite comparable. It was non-inferior. So both were similar. The mortality was also similar, slightly better with transvenous ICD, but not statistically significant. All complications, again, all complications were lower with subcutaneous ICD. And it is mainly the lead-related complications where it shines. And as we can see that the incidence was only 1.4% compared to 6.6% with transvenous ICDs. And inappropriate shocks were slightly more, but not statistically significant. And as we saw earlier, the same thing happened in this Praetorian trial also, that the inappropriate shock rate was quite similar with both, but most of the shocks were related to cardiac oversensing with subcutaneous ICD, and they were related to arrhythmia discrimination by the transvenous ICD. So as we can see, transvenous ICD was not as good as SICD when it comes to arrhythmia discrimination. But oversensing is seen more with SICD, and which is understandable because the sensing vector is very wide and entirely out of the thorax, out of the thoracic cage. So it is more vulnerable to outside influences as far as the oversensing is concerned. So the conclusion from this trial was that subcutaneous ICD is non-inferior to transvenous ICD with respect to the incidence of primary endpoint, that was the device-related complications or inappropriate shock. Now, this was another big trial in recent years, which is published in 2021, Untouched trial, where it looked at inappropriate shock-free rate at 18 months, because that is the main concern that has been one concern with the SICD. And it looked at the inappropriate shock-free state or rate of the SICD compared to transvenous. And what it found was that the inappropriate shock-free rate was 95.9%, which was better than the performance goal that was set. That was 91.6%. So as compared to performance goal, which was based on previous studies on transvenous ICDs, it set a performance goal of 91.6. But actual delivered performance rate was 95.9%. So there was a significant improvement over the transvenous ICD. So the conclusions was that SICD is non-inferior to transvenous ICD for incidence of inappropriate shock in primary prevention population. So this slide very nicely shows how this oversensing has been overcome by good algorithms in recent years. So we can see that in the blue we have the SICD group, And we can see from the early studies of high inappropriate shock rate, the inappropriate shock rate has progressively come down. And now it is around 2.5 to 3%. And in the transvenous ICD also, initially, when the SCUD-HAVE trial happened, the inappropriate shock rate was quite high. And with the better algorithms and better programming strategies, now it has been progressively brought down. As all of you are aware that now we are programming primary prevention ICDs in a different way. Previous programming used to be very aggressive, that we used, the ICD was programmed to react very quickly within seconds. Now we know that a lot of patients have self-terminated non-sustained VT episodes. So we are programming a longer detection intervals and longer and higher cutoff, higher rates also, so that slower arrhythmias and short-lasting arrhythmias are not reacted to by the ICD. So all that plus better programming has led to reduction in the inappropriate shock rate. This is another meta-analysis combining data from many trials, which again shows that the transvenous and subcutaneous ICDs are comparable when it comes to inappropriate shock rate. And in the pediatric, it can be even better. This is the latest trial which was presented last year, the ATLAS trial, where 500 eligible patients were randomized to SICD or transvenous ICD. And the primary outcome was major lead-related complications occurring within 6 months of implantation. And besides other things, the primary endpoint, as we can see, it was drastically different between SICD and transvenous ICD. So only 0.4% patients, that is only one patient, had lead-related complication as compared to 12 patients in transvenous ICD. So it's about 90% or more reduction in the between the two groups. Other things were quite similar. So this is another data which shows that lead-related complications are much better with the SICD compared to transvenous ICD. So what do the guidelines state? The guidelines have been quite, they're not very, I mean, this was like 2018 guidelines from AHA-ACC, which says that in patients who meet the criteria for ICD, but they have vascular access problem, we should consider subcutaneous ICD. Of course, after ruling out the contraindications, because patients who have bradycardia indication or require CRT as a treatment strategy, or we don't expect ATP, etc., we should prefer subcutaneous ICD in these patients where vascular access is a problem. And otherwise, also in any patient for that matter, any patient with indication for ICD, implantation of SICD is reasonable. That is class 2A indication, if of course there's no contraindication. But if the patient has bradycardia or requires CRT or requires ATP, so there we should not implant subcutaneous ICD till we have a pacemaker strategy available in the form of which is already being entered clinical trial, that there is a possibility of pacing via a leadless pacemaker. Till then, we should not use it. And these are relatively recent guidelines, 2022 guidelines from ESC. They again assign it a class 2A indication. So it should be considered as an alternative to transvenous defibrillator in patients with indication for ICD when pacing therapy or cardiac resynchronization or ATP is not indicated. So at the moment, it is indicated for largely for primary prevention for the kind of patient that Dr. Ajay Naik discussed in his talk. So what are the current concerns? The current concerns, one of them is lack of pacing capability, which is about to be addressed. Lower battery life. Now that's a major concern, and because the transvenous ICDs have really progressed when it comes to battery longevity. And now most ICDs offer 10 to 12 years of longevity, and some of them will offer up to 15 to 17 years of longevity, single chamber transvenous ICDs. The SICD also has become better, The first iteration was only 5 to 7 years, but now the latest model, it gives about 8 to 9 years of longevity. Sensing issues in some patients, particularly those who have, like for example, hypertrophic cardiomyopathy, etc. So some patients are more vulnerable to sensing problems, and the higher DFT necessitates a bigger size because the capacitors have to be big. The shock is 80 joules, so we need bigger battery, bigger capacitors. So the size of the device is also big, and the cost is significantly high. So these are the current concerns with the subcutaneous ICDs, and I'm sure many of them will be addressed in coming years. The future perspective, we are looking for a smaller device, better longevity, more programmability, more diagnostics, and of course, ATP, CRTO ready support through a leadless pacemaker. And this is not a fantasy, it is already there. With SICD, there is a leadless pacemaker available. It's called Empower, which has entered clinical trials now. And maybe the results are expected in 1 or 2 years, and then we will have this possibility. And this is a published case report where we can see that patient is in BT and ATP therapy is delivered through the leadless pacemaker, which terminates the tachycardia. So, friends, the take-home message is that subcutaneous ICD, we should keep it in mind when we discuss ICD with the patient, and it can be preferred in patients who have venous access issues or patients who are on like hemodialysis, where we don't want bloodstream infections or bacteremia. These patients are very susceptible to bacteremia. Immunocompromised patients, channelopathies, hypertrophic cardiomyopathy, previous device infection or lead failure, younger patients, longer life expectancy, and in women for cosmetic reasons. So we should discuss with the patient, and patient should be aware when the patient is making a decision. Patient should be aware of possibility of subcutaneous ICD. And of course, it should be avoided in patients who have wide QRS, who may now or maybe in future need CRT, patients with bradycardia who may require pacemaker support, and patients who have already demonstrated a monomorphic sustained VT for whom ATP therapy is deemed appropriate. So I think I will stop here. Thank you very much for listening, and I will be happy to answer if there is any question.
Thank you very much, sir, for a wonderful coverage presentation on the subcutaneous ICD. I'm just not sure what can be the cause of perforation in patients who have subclass infantry. Because one of the latest time you shared in patients subcutaneous ICD, there was cardiac perforation. So what?
No, I didn't get the question. With the subcutaneous ICD?
Yeah, the latest trial you showed in subcutaneous ICD group, there was cardiac perforation. So what can be the cause of?
No. I didn't show that subcutaneous cardiac perforation. Yes, well, I think cardiac perforation is not possible with this ICD, subcutaneous ICD. But when somebody is trying to tunnel the lead, one can definitely go through the thoracic wall and cause perforation. In that, somebody might have perforated right ventricle. It is theoretically possible if one is not careful, that when one is tunneling the lead along the subcostal margin and going along the sternal border, if one is not careful and one enters the thoracic cavity and perforates the right ventricle, that is the only thing that comes to mind. But it should not happen. It would be a very rare thing to happen.
Thank you. Any question from the audience? So, thank you very much, sir, for the nice presentation.
Thank you.
So I would like to call Dr. Kush Kumar Bhagat for next topic, extended cardiac monitoring and need of R.
Thank you so much, sir. So actually it's a very important topic, because many a times a patient comes to us with history of syncope or pre-syncope or sudden onset palpitation, and patient comes to me that he got a Holter monitoring done, and the Holter was normal. So patient comes to me that the Holter was normal, and I was advised that everything is normal, you don't have a cardiac problem. But actually the important thing is that you should get the ECG at the moment you have symptom, either it be palpitation, pre-syncope or syncope. it's very important to get event ECG. So if you don't have an event ECG, and if in 24 hours Holter monitoring, or maybe a 7 days Holter monitoring, if that report is normal and you didn't have any symptoms during that episode, then practically that report is of no value. So starting with that, I'll just present in brief about the various types of Holter which are available, the external loop recorders, the implantable loop recorders, the advantages, disadvantages. So the current techniques for arrhythmia monitoring, the most common technique is obviously ECG monitoring, which tells us about a very brief episode. Then we can go for Holter monitoring, which can be extended Holter monitoring for maybe 48 hours, 72 hours. Then extended external loop recorder, which is very easily available nowadays. We can implant these loop recorders from 3 days to 30 days. And then obviously implantable loop recorder. So now the external loop recorders, nowadays the external loop recorders, these are also very friendly. There's just a small patch which gets stick to your body, and we can get recordings for up to a month. And as far as guidelines are concerned, then definitely according to the symptoms, you should advise the technique. Suppose a patient develops symptoms every day or maybe every 2 or 3 days, then you can advise a 24 or to 72 hours Holter monitoring. If every week or every month, then depending on the duration, we can advise him or her Holter monitoring for external loop recorder for 7 to 30 days. Then obviously if the episode is less than once per month, maybe once in every 2 or 3 months, then we have to go for an implantable loop recorder. So these are the external loop recorders, which are simple patch which gets stuck to the body. Then there's one pocket ECG also. The advantage of this pocket ECG is that there's a live monitoring going on. In fact, I had a patient a few days back only. He had an episode of NSVT during the, he was at home, and I got a notification just half an hour later that patient had an episode of non-sustained VT. You can evaluate the patient. So that is the best part of this pocket ECG, that you can get the monitoring, live monitoring 24 hours per day. So this is the only FDA approved monitoring system. And this is most advanced ambulatory heart monitoring system. Now coming to the difference between ELR and Holter, obviously as far as the yield is concerned, it is less with Holter. Recording length is high with ELR. Definitely it's more comfortable to wear anything which is wireless, and you can take a shower also. Continuous remote monitoring, it can go up to 30 days. Patient compliance is better. And as far as installation is concerned, that is also very easy. And all the publications which were done, it has clearly shown that as far as the yield is concerned, then external loop recorders had got better yield in terms of palpitation, syncope, pre-syncope, AF symptom detection as compared to Holter monitoring. So guidelines also, they are recommending external loop recorders and implantable loop recorders with the class 1 and class 2A recommendation, depending on how frequent the symptoms of that patient is. Again, ACC-AHA guideline also, it also suggests that to evaluate selected ambulatory patients with syncope or suspected arrhythmic etiology, then we can go for the external cardiac monitoring devices, which can be Holter or external loop recorders or patch recorder. So then we have an implantable loop recorders. Again, these are very small loop recorders. So this is with the Biotronic system, and it's a very small kind of an injection. It's an OPD procedure. A patient comes to you with a very infrequent symptom, maybe symptoms of pre-syncope or syncope or palpitation every 2 or 3 months, then Holter monitoring, then external loop recorders, all that will be of no value. So you have to get either an event ECG, or you have to go for some sort of recording system in which you will get a continuous ECG monitoring of the patient. So this is one of the system. This is very small system. It's an OPD procedure to implant this loop recorder inside the body, just a kind of injection. We have to make a small nick, which can be made with this only, and then just insert the device in the chest wall. So this is actually how you implant the device. This is a blade, and the device is inside this system, and we can inject the system and inject the device. So this is how the device looks in the X-ray, and this is how it detects. So patient had an asystole, and we can see this is clearly we can see the EGM, which we can see the actual ECGs, and there was a sinus pause, and probably this was the reason for the patient symptoms, and patient can be advised a pacemaker or whatever we feel. So again, as far as tachycardia is concerned, and also especially in when patient has recurrent stroke. So recurrent stroke, if patient has, then many a times we get a reference from neurologist that do patient have atrial fibrillation episode, and most of the times they get a Holter monitoring done maybe 24 to 48 hours, and that is normal, and they believe that yes, there is no AF for that patient. But actually you have to go for extended monitoring for that patient, and that actually happened with this patient. He was implanted a loop recorder, and he had an episode of atrial fibrillation, and paroxysmal AF episode was the reason for that recurrent stroke in this patient. And the beautiful aspect of these devices are that they can go for a very long monitoring. With this device, you can go for a monitoring of up to 5.5 years, that you implant a device and you will get a recording for almost 5.5 years. So this is a very important thing. It can diagnose any symptoms, because of it can detect sinus pause, it can detect atrial fibrillation, it can detect ventricular ectopics, NSVT, VT runs. Then there's another system available with Abbott, which is called as the Confirm RX. Again, a very, very small device. We can see 5 centimeter into 1 centimeter. It's a very small device, very slim and thin. Same technique of implantation. So these are the loop recorders, external and the internal loop recorders, which are available. So we have smart watches as well. So I think most of you have Apple iPhone, and you can have a smart watch. So in the smart watch, I think I don't know the series, but after a particular series, you can get a ECG monitoring. You can get a ECG of yours in your phone. So you can send that ECG in a PDF form to your doctor or anything, and many times it has helped us in detecting atrial fibrillation, PSVT, sinus pause, the cause of syncope, which can be complete heart block. So that is also very useful nowadays, the Apple iPhone with a smart watch. So this is how we go for these loop recorders and loop monitoring. Now I have few cases, just 2 or 3, 4 cases I'll show. So, so this was a female with history of palpitations, and she was advised Holter, which was normal. And since I think the episode was every 4 or 5 days, she was advised external loop recorder. And then clearly we can see that patient had an episode of atrial fibrillation, which was diagnosed with external loop recorders, not with the Holter monitoring, because the episode was not very frequent. So depending on the symptoms duration, I mean, when the symptoms happens, whether it happens every day, every 5 or 6 days, every month, or every once in 3 or 4 months, according to that, we have to advise whether patient should go for an external or an internal loop recorder. Again, second case, patient had palpitations. Yeah, patient had palpitation, and this was NSVT, which was detected with ELR. This was a female patient with history of infrequent syncope. Holter was done, ELR was also done normal, and patient was advised an ILR, which showed sinus pause. One more patient with a history of syncope, and again, so this was again a sinus pause, long pause, which was detected in the loop recorder. You can see, so this was the cause of patient symptoms. And again, one more female patient with history of pre-syncope and multiple hospital visits, but by the time she visited hospital, her ECG was normal, and this was the AV block, which was diagnosed on external loop recorders. So I just mentioned about the recurrent transient ischemic attack or recurrent pre-syncope patient. Mostly they have atrial fibrillation, but most of the times the Holter or the ELR is normal. So we can either go for external loop recorder for 1 month, and if that doesn't picks up this atrial fibrillation episode, we can go for a implantable loop recorder as well, because then the treatment will vary for this patient. If patient has atrial fibrillation, then probably we have to give NOACs to the patient. So just to conclude, ELRs are indicated in patients with palpitation, pre-syncope or syncope who have intersymptom interval of around 4 weeks. ALRs are indicated in patient with, ILR. So it's ILR are indicated in patient with palpitation or pre-syncope with intersymptom interval of more than 4 weeks, and these are diagnostic for the therapeutic decision only when a correlation between symptom and arrhythmia is detected, and definitely the diagnostic value of Holter, these loop recorders are higher than the Holter monitoring. So I would love to have any questions.
And definitely there is no doubt about that the ELR, the extended recording cardiac monitoring is better than the Holter. But if we are going to other modalities, like in patients with syncope comes to you, there are infrequent symptoms, do a test like tilt table testing or EP diagnostic EP study, do they have some additive value, or should they be advisable?
Yes, sir, definitely, sir. So if a patient has suppose left bundle branch block in the ECG, and patient complains of syncope, not very frequent but infrequent, maybe every 2 or 3 months, then you believe you have ruled out other neurological causes, and you believe that it's a cardiac syncope, then you can go for an EP study and measure the HV interval. So the HV interval is high, maybe more than 100 milliseconds or 95 milliseconds. Then you can, with a class 2A recommendation, suggest that patient will require a pacemaker implantation. Similarly, if you have some sort of sinus bradycardia in the ECG, or maybe some sinus arrest in the ECG, and still you believe that patient can have 6 sinus syndrome, we can go for sinus node recovery time and CSNRT test in these studies to just diagnose the 6 sinus syndrome. So if they have long pauses in the EP table, we can diagnose that 6 sinus syndrome. We can go for pacemaker implantation in those patients. The role of tilt table testing is also there, sir, but especially in the diagnosis of this POTS and all. If a patient comes to you with syncope, we should, apart from neurological evaluation, we always try to go for tilt table testing. And we have few patients they have actually had POTS, postural orthostatic hypotension, and so definitely these tests help. But if we have ruled out all these things, then we should go for either ELR or ILR, so just to make sure what actually happened at that time of syncope, sir. So but if that is normal, if patient has syncope and then ILR and ELR finding doesn't suggest anything, then probably we are not dealing with any cardiac cause, sir.
And how often you goes for the cardiac MRI? If a patient comes with a cardiac MRI just to rule out any structural heart disease which may be present, which is not picked by the echo. So patients with some symptoms and everything is fine. So how, what is the indication and how you choose to go for a cardiac MRI in these patients?
So usually, sir, I don't have much experience of using cardiac MRI in patient with syncope. So after if ECG is normal and echo is normal, and if maybe angiogram or a CT angiogram, if patient is, more age is more. But after that, I don't think that for syncope I have anytime advised the cardiac MRI. Maybe, sir, any of ma'am or sir would like to answer cardiac MRI for a syncope patient. A patient comes to you for syncope and you advise the cardiac MRI for that patient.
Yeah, younger patients where you suspect the syncope maybe because of arrhythmia. There are a lot of patients who may be having the sarcoid or some infertility. Their MRI because the echo will be normal most of the time.
Echo will be normal. Yes, ECG also.
The patient may be having arrhythmic. The syncope, the cause of syncope is arrhythmia. I think MR has definite role.
Okay.
Especially contrast enhanced MR.
Yeah, I think if somebody, we find some PVCs or NSVTs on Holter, but still we are not sure why the syncope has happened, just to rule out ARVT, sarcoidosis and all, we can do cardiac MRI.
Thank you, sir.
Any questions from the audience? Thank you, Dr. Kush. For the last presentation of this session, I'll request Dr. Makkar for how to choose your ICD, a single chamber, dual chamber, or Dr. Makkar.
Okay, thank you, sir. Good afternoon. So I'll just go through my slides very quickly. It's a long talk, but I'll wind up in 13-14 minutes. So basically it is the comparison between single chamber ICD, a dual chamber ICD, and a novel technology called DX ICD, which has a dual chamber facility with single lead. 90% of cardiac arrests are due to VT-VF, and how this is why the ICD has been so popular and so much used world over. But there are some problems inherent with the ICD. One of them is inappropriate shocks. Inappropriate shock means shock not received because of a true VT or VF. If it is received for atrial fibrillation, supraventricular tachycardia, or non-sustained VTs, or if it is because of some sensing, over-sensing thing, then it is inappropriate shock. And what if silent AF is not detected by subcutaneous ICD? Single chamber ICD. Single chamber ICD will not be able to detect atrial fibrillation because it has no atrial channel. So then what is the solution? So shocks are okay, they are life-saving, but they have a lot of adverse effects. It reduces cardiac output, and if some heart failure patient receives lot of shocks, it can be a reason for decompensation of heart failure. Quality of life, of course, is reduced by the shock, and sometimes we call it as ICD neurosis. And if somebody receives frequent shocks, it may take years to get out of that fear that he might get a shock anytime. ICD can be pro-arrhythmic also. Like in this example, you see that it was atrial fibrillation here, irregular rhythm. So these are electrogram, not surface ECG. Electrogram retrieved from ICD. AF here, then it considered as VT, gave ATP, and eventually it converted AF to VF, and then shock was received. So this is pro-arrhythmia which ICD can have. Inappropriate shocks are quite common, most commonly because of AF, then SVT, then abnormal sensing, and inappropriate shock increase mortality also. So then what? Dual chamber ICD or single chamber ICD or any other option? So one advantage with dual chamber ICD, of course, is the atrial pacing. So if somebody has a Brady indication like bradycardia with VT protection, then of course we'll give dual chamber ICD or CRTD if applicable. Otherwise, the non-pacing indication, non-pacing benefit of a dual chamber ICD is atrial sensing and atrial high rate event. It is sometimes difficult to differentiate between flutter or fibrillation or atrial tachycardia in electrogram. So they are called AHRE. This is a relatively new term, atrial high rate episodes, which can be responsible for stroke. So it needs to be, ICD need to sense that, and we have to act by giving anticoagulation to prevent these strokes. So these are a few trials which showed that AHREs are associated with high risk of stroke, and we can prevent them with anticoagulation. So dual chamber ICDs reduce clinical adverse event related to atrial fibrillation when compared with single chamber defibrillator. So it was a sub-analysis of DATA's trial. So this is proven now that the dual chamber ICD is better in detecting AF and preventing the stroke. So this was interesting trial where the population was randomized to dual chamber ICD, single chamber ICD, and dual chamber ICD, which was used as a single chamber ICD. So conclusion was that dual chamber ICD in comparison with single chamber ICD reduced the incidence of clinical endpoint composed by permanent AF related hospitalization, ICD shocks deemed inappropriate due to AF misclassification. So these are the benefit of dual chamber ICD. But is dual chamber ICD definitely better than single chamber ICD? Not actually. This is a analysis which shows that there are more complications, lead related complications, more hospitalization, more even mortality with the dual chamber ICD. Probably because these patients may be more sicker than that. Like in India also, the CGHS and other reimbursement rates are such that most of the centers are implanting dual chamber ICD for non-pacing indication also. But it is related with high rate of lead related complications and poor outcomes. So, so besides more lead related complication, dual chamber ICDs has similar efficacy and all complication as single chamber ICD in secondary sudden cardiac death prevention. So definitely other than AF, I don't think there is any advantage if patient doesn't need atrial pacing. So then what if we don't want an extra lead and we still want to sense the atrial fibrillation? An easier way is to use just like a VDD lead, where the atrial channel is there on the ventricular lead. So single lead works as atrial sensing and ventricular pacing. So it detects atrial fibrillation, also reduces inappropriate shocks, avoiding the lead related complication. So single chamber ICD system with complete atrial diagnostics, ease of implantation, less hardware, single lead, less complication, atrial sensing and diagnostic, optimize AF management and safe shock reduction. So this is the single lead which has atrial channel, and in comparison to the older VDD systems, the P-wave sensing is really good. Whatever DX ICDs I have implanted, P-wave of 3, 4, 5 is normal parameter. This is how it looks like on X-ray, single chamber ICD with the atrial sensing electrodes. So this is how electrogram looks like. Beautiful atrial electrogram can be recorded from this sensing channel. So, so dual chamber ICD has more lead dislocations, more pneumothorax, obviously lead related complication, and all cause mortality is also more in dual chamber ICDs. So we can use this DX ICD as a single chamber with advantage of all dual chamber ICDs. So ADRIA study concluded that it can be implanted faster. It is equivalent to a standard DR ICD with regard to ventricular tachyarrhythmias and detection of VT as well as SVTs, and it represents a useful alternative to obtain atrial sensing. So this is how atrial tachycardia is being sensed, atrial fibrillation is being sensed by the atrial channel. So this is DR smart, VR simple and CRT capable. DR smart means the single lead is acting like a dual chamber lead and has all advantage of with high diagnostic accuracy to sense the atrial channel. It amplifies the atrial electrogram for better sensing. It reduces HF hospitalization and improves outcome also, a result from COMPASS study. So it is now a decade of proven performance. It's not a new technology anymore. We have large volume of DX ICDs implanted, the patient who are doing well. So it is VR simple, means is as simple as a single chamber ICD or single chamber pacemaker as far as implant procedure is concerned. So fewer peri-procedural complication and reduced mortality with this DX ICD. Reducing ICD implant complications may substantially reduce cost of hospitalization. So if patient comes with a, misplaced or displaced atrial lead or ventricular lead, it has additional cost to it. So eventually the DX ICD is economically also more viable than a dual chamber ICD. Economic impact of cost effectiveness, as I explained, that the dual chamber ICD has hidden costs of re-hospitalization and re-procedures which may be avoided. So MRI conditional DX system is available as VRTT DX or CRTD DX. So here you can see the comparison, single chamber defibrillator, DX system and dual chamber defibrillator. So AF detection is not there here. So everything which a dual chamber ICD has, it can be done by the DX ICD, like SVT discrimination, lower complication, lower procedural complexity. Only when you need atrial pacing, then dual chamber ICD is obligatory. Otherwise, all dual chamber ICDs can be replaced by DX ICDs. That's the message I want to give here. So it is CRT capable. So now we talked about DX ICD. Now a little bit about DX CRTD. In DX CRTD, it would be actually 2 leads in place of 3 leads. One for the, I'll show you, one for the right ventricle and right atrium, right atrial sensing, right ventricular pacing, and one for the left ventricle. So 2 lead CRTD system is possible by DX ICD. But again, if you think that patient might need atrial pacing in the future because of therapies like amiodarone sometimes, or beta blockers or other antiarrhythmics, then it is may not be a good idea. But if you think atrial rate is very good and patient doesn't have any component of sick sinus syndrome, DX CRTD can be implanted with one less lead and with good atrial diagnostics and atrial sensing. So equivalent CRT therapy with less hardware. So all the benefits of CRTD can be obtained with one less lead. That's the CRT capable thing. So again, as I told you, if atrial pacing is not needed, then the patient is an eligible candidate for CRT DX. And again, only difference is that atrial pacing cannot be done. Otherwise, CRT DX is equivalent to CRTD, conventional CRTD. So again, this shows the that this is the single lead with all the functions. Thank you so much. Thank you.
Thank you, Dr. Shankar. Any questions?
Sir, I just want to ask about the lead, because the lead, DX lead, has a atrial sensing thing, which is a fixed site, distance from the apex or the lead distal end. So in different cases like large hearts, small hearts, do the same leads do perfectly, or you do some there are some techniques to optimize that in different kinds of structurally different hearts?
Only the length of lead is good enough, so it is only the loop which you have to adjust. So whether large heart or small heart, it is just the loop which you have to adjust little bit more or less. Otherwise, there is no separate technique is needed.
Not different specific.
Yeah, and it actually amplifies the atrial signal. The device amplifies the atrial signal very beautifully, selective atrial signals. So sensing is not an issue with DX ICDs. Atrial sensing is not an issue. Just like, unlike the VDD systems we used to use 10 years before, there are a lot of problems with sensing, but this is good.
Thank you, Dr.
Okay.
Matkar. I think we close this session. Thank you.
Yeah.
Sir, please be available there only. So, as we move forward in our conference, we are about to begin the session on Complex Arrhythmia Symposium. Our expert is ready to share their valuable insights and knowledge in crucial area of cardiology. Enjoy the session and stay engaged and ready to contribute. So for this, I would like to invite Dr. Sahil Jindal, sir, as a chairperson of this session, and Dr. Supriya Jain, sir. And thank you for being a part of this enriching experience. And I will request Dr. Daljit Kaur for the next presentation. Thank you.
once again, I'd like to thank Dr. Makkan and Dr. Kush Bhagat for having me here. So next 15 minutes, I'm going to show some case example where radiofrequency ablation, apart from SVT, other cases, made a difference in the outcome, major difference in the outcome of the patients. So that's my first case. 53-year-old male tobacco chewer, shortness of breath, had chest pain of 5 days, and he went into heart failure since last 2 days. He had an anterior wall MI, and obviously he reached little late in the hospital. And that's the LED which was cut down and it was stented. Good outcome, everything good. Patient was shifted out. And after few hours, this is the ECG. You can see that anterior wall is scarred already because patient has reached late. So there is the R wave is gone from V1 to V3 or V4. So you know that anterior wall is gone in this patient. So after few hours, this patient arrested in the post-cath ward in the ICCU, and then he was given a shock, and you can see a ventricular fibrillation. It is going on, shock, reverted, and all good. So what do we do? What's the common practice? Post-PTCA, patient had a VF, arrested, what do we do? The commonest thinking is, so you have arrested, resuscitated, because he had 2-3 episodes of more arrest. The commonest thing is he was sedated and check angio done. He was put on IBP because he was in failure. And the first thing we do is check angio to see that whether the stent is patent or now it's thrombosed again, but the stent was patent and it's a flowing vessel. Now what do we do? So next line of therapy is you try to calm down the patient, right? So patient had multiple VF episodes, was given general anesthesia. He was started with the low-dose beta blocker infusion. Amiodarone was tried. So different antiarrhythmics at different time point in different doses, whatever available was tried. Electrolytes were checked, which was normal. Next 2 days, this patient was under general anesthesia, and without exaggeration, he received more than 200 shocks. So what's happening here? You can see that. So why this 12-lead ECG is connected? This was kept connected on his chest to see that what's happening. You can see that it's a drop of the head. The patient is developing ventricular fibrillation, or you can call this as ventricular flutter. So this is what you try to bring up. Can you see there is one PVC, which is a single morphology PVC. Yesterday we saw something called long QT syndrome, right? So there's a one PVC which is triggering, and the second PVC which is happening on the T wave of the first PVC, and that's why patient was going into polymorphic VT or ventricular fibrillation. And it's a single morphology PVC which is causing all this, which is failing to, it's getting suppressed with any kind of therapy. And now here what you can see is what we did is we thought let's temporarily pace atria. You can see P wave is negative in 2-3 AVF. So sometimes if you pace atria faster rate, you can suppress PVC. So that's what was tried, but you can see that still these PVCs were coming. So for some time he calmed down, but again he went into ventricular fibrillation. So these kind patients, if you take for ablation, you can see it's a PVC which is coming in the bigemini. So I'm not going to go into detail. Even in the during electrophysiology study, you can see that patient is going into ventricular fibrillation. So what do? This is all red area is a complete scar, dead area, LED territory is gone. Here you do something called scar modification. And then the PVC which was there, you try to go at a particular site from there, PVC is coming, you localize that and ablate. And you can see this is after the ablation. Now you can see it's a clean sinus rhythm. First time you're seeing the sinus rhythm and the P waves are normal, you have stopped pacing, and then you try to pace and see whether you can induce the ventricular tachycardia. You're not very aggressive. You induce, there is nothing coming. So he was stabilized, he was not affording for ICD, stabilized for heart failure, given some donated ICD and discharged. So this makes a very big difference in the outcome of the patient. This is a second case. So first case example was VT storm after revascularization. This is a second case example. It's an ARVD, already given an ICD. He had a VT and he was given an ICD. And he was having a VT storm again. This patient was from another country. Cardiac MRI was not done. And over the last 5 years, he received 2 ICD implantations. So 3 procedure ICD because he had a lot of VT episodes. Multiple episodes, multiple therapies, whatever available drugs tried. And this time, this third IC also reached ERI. So this is the device log, and you can see the number of shocks. You can see the timing here. So one date, and after every few minutes, patient is having VT and patient is having shocks. This is how he reached the hospital. So this is another case scenario. It's a drug refractory ventricular tachycardia. And you can see this is an ECG of this patient. So you can see this is a classical ARVD. You can see this is an epsilon wave, which we teach our students, V1, V2, V3. There is an ST coving and there is an epsilon wave. And patient has already developed severe RV dysfunction. Right ventricle was also dilated. So ARVC is a disease which is, the disease progresses from epicardium to endocardium. So it's more of epicardial disease. Epicardial scar will always be bigger than the endocardial scar. So these cases you have to do epicardial ablation upfront. So these patients need epi-endoablation. So this you can see the huge RV. This is a PA view in the cath lab. In your catheter, this is reaching here. So it's a big RV in this patient. You take an epicardial excess. This is your catheter, which is in the epicardium. And this is the epicardial map. I'm not going to go into detail of this, but all this gray area is epicardial scar. It's a big scar, and only islands of normal myocardium. Same thing for the endocardium. This is an RV endocardium. This is a site where your lead was there. That's why there is no geometry. But again, you have a big scar. There is a basal aneurysm. I don't know whether you're able to appreciate. But what you do in this patient, you perform VT ablation, both activation mapping, substrate mapping, whatever in the EP lab we do. This is a comparatively long procedure. It takes 5 to 6 hours to do this ablation. And the post-ablation you see, you pace, you try, you have given 3 extras, program extra stimulation, there is no VT. This patient has completed more than 24 months of follow-up, sent back to his country where he got an ICD again implanted, and he's doing good. There are no VT episodes. He needs medical therapy, lifelong medical therapy, because ARVC is a progressive disease, but you have improved the quality of the life of the patient. This is another case. I think this case I showed yesterday, 9-year girl, fatigue, dilated cardiomyopathy. This child was roving around with the diagnosis of the end-stage heart disease. I'll show you this. So this child had a simple fascicular VT. You can see it's a right bundle, left axis with a VA association. I yesterday spoke about carotid sinus massage, and you can demonstrate VA dissociation. Now P waves are walking through, and this is the echo of this child. It's a severe LV dysfunction, and child was on propranolol amiodarone, but this child didn't have a sinus ECG. So this is called incessant VT, that is hemodynamically stable VT going on for weeks to months, and it will cause slowly left ventricular dysfunction. So it is called arrhythmia-induced cardiomyopathy. Many times we don't know whether arrhythmia has caused cardiomyopathy or cardiomyopathy has caused arrhythmia. So unless you suppress the arrhythmia, you won't know what's happening. So again, this child has tried everything starting from Bitola, amiodarone, lidocaine, overdrive pacing, DC cardioversion. Surprisingly, this child has never reverted to sinus rhythm. Everything failed in this child. You shift, you can see it's a simple procedure. This is not a complicated procedure. You can see this halter. It's a VT going on. This is a side, and you ablate here, and you can see the first time you can see sinus rhythm of the child. So this is the reversion, and you can see ECG. Now if you see ECG, you can see memory T waves because she was in VT for long. And you can see there is a P wave which is little enlarged. There is an LA enlargement, evidence of LA enlargement in V1 because a big terminal component. And after 1 month, you see that EF has improved, drastically improved, and your terminal negative component has gone, V1. So this child now has developed completely normal EF. She doesn't need any therapy. She was roving around with dilated cardiomyopathy, almost kind of end-stage heart disease. A simple ablation has changed her life. This next case example of 56-year-old male, dilated cardiomyopathy. He was severe LV dysfunction, and he had a posterior basal aneurysm. So imaging is very much helpful. I think we have a next session on imaging. So there's a huge posterobasal aneurysm you can see, and this person had a PVC of very high burden of single morphology, which is coming from this aneurysm. So you take this patient for the ablation. You can see this is a big aneurysm, and because the PVCs are running very quickly, you can do an activation mapping. You can localize that, and you can see once you start ablating, here I have marked it, you start ablating, and by 8 seconds of ablation, this PVC is suppressed. And this is in the lab, the Holter, when you took the patient, there is a PVC is running, and the post-ablation, there is no PVCs, it's completely suppressed. And the posterior basal aneurysm itself will not cause severe LV dysfunction, right? Because it's sitting in the basal and the posterior part. So his EF improved, it didn't become normal, but it drastically improved, and he is on guideline-directed medical therapy. This is a next case example of ischemic cardiomyopathy who was given a CRT-D, and he was referred as a CRTD non-responder on guideline-directed medical therapy. He had a multiple heart failure hospitalizations and renal failure. And that's the ECG of the patients. Now you can see there are a lot of PVCs here. Here, you cannot blame CRT. For the CRT to work, what do we need? The CRT has to work beat to beat. That is 24/7, more than 99% V pacing or bi-V pacing for the CRT to show an adequate effect. Here CRT cannot work, right? Arrhythmia is one of the very important reason for a CRT non-responder. So you have to suppress this arrhythmia. So lot of drugs were tried to suppress this arrhythmia, not able to do that. But because of this arrhythmia, different permutation combinations were applied to suppress this arrhythmia, including increase in the pacing rate, but this was not suppressing. You take this patient in the lab, there's a single predominant morphology of the PVC. I've highlighted that. You go at one site, you can see you ablate that site. This is a site where the ablation was done. This is a position of the catheter. And you can see this ECG, this is a post-ablation ECG of the patient. And you can see now the bi-V pacing. There is a huge difference in the bi-V pacing before the ablation because there was an arrhythmia going on. You were not able to give adequate bi-V pacing to the patient. So this is a case example where you have given a CRTD, but the patient is diagnosed as a non-responder because of arrhythmia and there was no adequate bi-V pacing. This is a case example of a 53-year-old male, hypertensive diabetic. It's a drug-refractory paroxysmal atrial fibrillation. It's not a simple supraventricular tachycardia. But why I have put this case is I would like to show. So he had, every few seconds he was in atrial fibrillation. He had very frequent short bursts of atrial fibrillation. You can see here in the Holter itself, like few beats of sinus and then he goes into the atrial fibrillation. So I think we discussed about this yesterday. So we have done a radiofrequency ablation where you do pulmonary vein isolation and you can see that the arrhythmia has terminated. And the post-ablation, even you pace, there is no arrhythmia going on. So it's not so complicated. If the patient is drug refractory, CHAD-VAS score is high, you know that there is no residual comorbidities to treat. You can take these patients for pulmonary vein isolation, can have a good outcome. This is my last case. I think I still have time. This is very interesting case. This is a 17-year-old boy who was referred from another center on ventilator as a survivor of SCD. He had multiple episodes of documented VF with seizures which were defibrillated. In our emergency, he had 10 to 12 episodes of VF. Echo was normal, electrolytes normal, no comorbidities. Family history, no major medical illness, no family history of SCA. And in the treatment, this boy was on phenytoin, amiodarone, and lidocaine infusion. And this is the ECG. I think a cardiologist sitting here will be able to diagnose this. There is a ST elevation in V1, V2. So it's looked like a Brugada ECG. It's a Brugada type 1 ECG. And in the Brugada, we cannot give the drugs this patient is taking, especially phenytoin. So anyways, this is the first ECG in the emergency. This was in 2019. I have deliberately kept the date. And then this is, you can see, he had a polymorphic VT with normal QT. He had a multiple this is atrial fibrillation, he had atrial fibrillation. He had multiple morphology of the PVCs, you can see that. He had ventricular fibrillation, everything, it's a single strip. He had everything, it's a zoo of tachycardias going on in this patient. So anyways, we stopped phenytoin, amiodarone given, lidocaine, we stopped all these 3 drugs. So in the Brugada syndrome, what do? We started with isoprenaline infusion, cold saline irrigation was given, and this guy settled. So ECG, I just wanted to highlight that after some time when this is the parasternal ECG, you can bring about proper Brugada pattern because it involves the outflow region. So once the VT storm got settled, we did cardiac MRI, and it's an unusual. In the MRI, he had a scar, you can see. You have a right side of the septum scar, there is some RV scar. It was unusual for a Brugada, so PET CT done, there were a lot of nodes there. So he was treated as a tubercular sarcoid. He was doing good for 3 months. So I was very happy, and he was given a donated ICD. After 3 months, you can see there's a resolution of inflammation, nice. He again came at night. So the 1st September he came, he was again in VF storm. So I was very happy because happy in the sense means I knew how to treat this patient. You can just give cold saline and isoprene in infusion, he'll get settled. I was thinking like that. So by now the disease had progressed. You saw first ECG, it was completely normal ECG. Now this boy has developed right bundle branch block, and again there is an atrial fibrillation. You can see there's an atrial fibrillation going on. So my confidence was like, let's give isoprene in infusion. He didn't respond. I gave cold saline irrigation, he didn't respond. I gave hypothermia with the help of critical care, he didn't respond. He was like having a VF every 2 minutes or 3 minutes. Gave general anesthesia, completely knocked down, he didn't respond. Then I thought, okay, let's try the regular treatment because of failing there. You're losing the child, you're failing there. It's not affording. We were thinking to put him on the ECMO, but it was not affording at all. So I said, okay, try metoprolol, didn't work. I tried lidocaine, it didn't work. Because he had AFib episodes also, and it was looking like it was pushed against the wall, I tried ibutylide also. It didn't work. Last, I arranged quinidine after 2-3 years, and through Riles tube, I gave one quinidine. Quinine, sorry, not quinidine. I had a quinine from medical college I arranged, and I gave through Riles tube, it didn't work. So what I realized, I had to give shock. I switched off the ICD because you cannot keep ICD. It was donated, already draining. So what I did was, instead of 200 joule shock, I realized that now, because it was a midnight, gave 49 joule shock, it reverted. So I was very happy. I came down to 10 joule, it didn't revert. So again went to 30 joule, it reverted. So whole night we gave some 300, 400, 30 joule shock. And early morning we took him for radiofrequency ablation. So when we took for, you can see that there is a PVC, and after each PVC there is a drastic ST elevation. After that it gets settles. So this is a repolarization abnormality was there. So Brugada, again you have to do epicardial ablation. So epicardial, this is an epicardial map. He had some scar which is unlike, so there's an overlap. We can discuss about it, we can debate about it. It's a Brugada phenotype. They call it as a Brugada phenotype. Anyways, epicardial, there was a big scar, both endo-epi ablation done. This PVC was mapped, was ablated, and this is an ICD, and this is a ECG post-ablation. So this case is, I published this case, this RBBB persistent. He's under follow-up since 2019. Recently, I've done a pulse generator change. Over last 3 years, he got 2-3 shocks. Once in a year, he comes with some shock. Thank you very much.
Thank you, ma'am, for a nice presentation and such cases. I just want to ask you about the role of cervical sympathy in these kind of resistant arrhythmias.
So all these cases, starting from the first case, because of I wanted to show some cases, you should try cervical sympathectomy. And even if you feel that patient is responding, you can go for permanent bilateral sympathetic denervation. Can be tried. This is one of the modality, right?
Ma'am, post MI when you have got stent patent, so whether, and we have got a VT storm, whether propranolol is a better drug than metoprolol? Is there any
There
evidence?
is some data saying that non-selective beta blocker have some better antiarrhythmic properties than the selective beta blockers. You can try, we also do that. So everything was tried in this patient. So I can very well understand that from one beta blocker, you can change to second beta blocker. You can try that.
Thank you.
Thank
a
you.
lot. Any questions from audience? Thank you.
So thank you very much. As we approach the final session of today's insightful symposium, we would like to extend our heartfelt gratitude to each one of you for your active participation and engagement throughout the day. So now let's dive into the concluding session of the role of imaging in cardiac arrhythmias. Get ready to explore the crucial role that echocardiography and MRI play in enhancing our understanding of these conditions. So without further ado, let's begin this enlightening session. Enjoy and thank you. And we would like to invite Dr. Hemant Chaturvedi sir for this presentation. And we would like to invite Dr. Ram Chitlangia sir to chair the session. Dr. Ram Chitlangia sir. ये सेट कर So let's take a moment to appreciate the dedication and hard work of our organizing chairman, Dr. Jitendra Singh Makkad sir, and organizing secretary, Dr. Kush Kumar Bhagat. So give them a big round of applause. This is the last session. And their commitment has been instrumental in bringing this event to life and creating this platform for learning and collaboration. Thank you.
Good morning, all of you. So I have been given this topic, that role of the echocardiography in the ICU settings. So in critical care echocardiography, basically we see in the typically best suited for the patient with the imminently life-threatening processes to categorize the shock and the respiratory failure, to check for the coexisting diagnosis and complications of the therapy, and to track the evolution of the critical illness by the serial examinations. So basically, we see that management is decided in cases up to 50% cases, immediately change in the management seen in the shock cases in the critical care echocardiography. So these are the common clinical scenarios that requires the echocardiographic assessment in the ICUs. So hemodynamically instability in the sepsis, left and right ventricular failure, acute coronary syndrome and its complications, hypovolemia, acute valvular dysfunctions, infective endocarditis, cardiac tamponade, pulmonary embolism, aortic dissections and ruptures. So this is a beautiful flow chart. We see these common clinical scenarios day by day in ICUs. Here are a few clinical scenarios and their differential diagnosis, like that of, in case of dyspnea, it could be due to the pulmonary embolism, or it could be the cardiac tamponade or the acute valvular disease. In case of hypotension, it could be the LV underfilling, that could be due to the hypovolemia, like that of in case of dehydration, bleeding, anaphylaxis and sepsis, or it could be the high LV filling pressures, like that in, or due to the severe LV dysfunctions, like that of in myocardial infarction and its complications, or it could be due to the myocarditis, Takotsubo syndrome, cardiomyopathies, and in case of chest pain, like that of aortic dissection. So first thing is in sepsis in ICUs. So why echo is important in sepsis? Because it represents the complex situations where the early hemodynamically assessment and support is the key of the sepsis. Most of the time heart is the victim, and sometimes heart may be the source of the sepsis also. So evidence showed that the use of the echocardiography in the septic shock leads to the change in the therapy in the large number of patients, majority of which concerns volume status in the inotropes. And using echocardiography in the emergency department, it shows that patients with the undifferentiated shock had a specificity of 94% of the identifying the sepsis. So these are the few cardiac abnormalities we see in the severe sepsis, like that of left ventricular dilatation, left ventricular global and segmental wall motion abnormalities, and left ventricular diastole dysfunctions, airway systolic or diastole dysfunctions, ventricular outflow tract obstructions, and valvular lesions, functional or endocarditis. So let's come to the few examples, like that of a patient with the chest pain with the hemodynamically unstable conditions. So in your first picture, you can see that this is a aortic dissection. So here is a intimal flap, you can see very well. And in the second case, this is the cardiac tamponade case. There is a massive pericardial effusion, and not only the pericardial effusion, but there is a significant diastolic collapse of the right ventricle. And here is a third case, like that of pulmonary embolism, significant dilatation of RARV. So I will go in a few cases examples and few cases scenarios later on. In ICU, the most important thing is that is the hemodynamically assessment. So we can do what hemodynamic assessment in the ICUs and help in the ICU cases, like that. First is the stroke volume and cardiac output assessment. So stroke volume, we can calculate stroke volume by in the parasternal long axis view. Here we go to measure the stroke volume for the LVOT. So LVOT is measured just few millimeters away from the aortic annulus towards the in the LVOT, and here is the dimensions. You can see in your first picture, and in the 5-chamber view, we just go by the pulse wave in the LVOT and goes as a trace the curve, and we by these two dimensions we get the stroke volume by the echocardiography machine itself. And once we got the stroke volume, then we can calculate the cardiac output, stroke volume multiplied by the heart rate. So one of the important thing in the critical care, that is the stroke volume and the cardiac output. So here we can assess these two things. Now next is the left atrial pressure estimation. So combining the transmitral Doppler blood velocities with the tissue Doppler velocities, we show in the good correlation with the left atrial pressure. So here in the first picture you can see this is a transmitral Doppler pulse wave. So E and A wave, E is the early filling and the late atrial contraction. And in this your second picture, medial and lateral mitral LS, you can see the tissue Doppler velocities. So E by E dash ratio is calculated, and here when the ratio is less than 10, it corresponds to the left atrial pressure is less than 15 millimeter of mercury, and when this ratio E by E dash ratio is more than 15, it corresponds to the left atrial pressure more than 18 millimeter of mercury. Again, pulmonary artery systolic pressure, one of the very important thing in case of critical care. So in peak pulmonary artery systolic pressure is calculated from the peak Doppler velocity of the tricuspid regurgitation by the continuous wave. So here in the picture you can see that we go by the continuous wave estimation, Doppler estimation of the tricuspid wall, and RV pressure is calculated as a 4V square. The V is here, it's a peak TR velocity, and once the RV pressure we are estimated, then RV pressure is added by the estimated RA pressure, right atrial pressure. It goes, it equals to the pulmonary artery systolic pressure. So here comes another thing, another question, that how can we assess the right atrial pressure? So my next slide for this, the right atrial pressure, we go for the subcostal study, and in the subcostal study for the IVC estimation. So these two pictures shows. In the first picture, this is the end expiratory period. So here we see, we measure the IVC dimension is the maximum dimension at the end expiratory period, and then just after the brief sniff of the patient, again we measure the dimension of the IVC. And here is the estimated values of the right atrial pressure according to the IVC diameter and the respiratory changes. So in first scenario, like that, in IVC diameter is normal, that is less than 21 millimeter, and if the respiratory changes is more than 50% of the inspiratory collapse, then the estimated right atrial pressure would be 3 millimeter of mercury, that is ranges around 0 to 5 millimeter of mercury. And in case of when the diameter is normal in the size is equal to less than 21 millimeter, but still here the inspiratory collapse is less than 50%, then the estimated right atrial pressure would be 8 millimeter of mercury. And in case when then the IVC is dilated, then it is more than 21 millimeter, but still it is collapsible and more than 50% of inspiratory collapse, then again the estimated right atrial pressure would be the 8 millimeter of mercury. In the worst scenario, when the IVC is dilated, that is more than 21 millimeter, and inspiratory collapse is less than 50%, then the pressure is the highest one, that is more than it's 15 millimeter of mercury, the range is around 10 to 20 millimeter of mercury. So by this we can get the right atrial pressure estimation. Next slide is for volume responsiveness, because in critical care areas the volume responsiveness is one of the important thing. So echocardiography allows to assessment of the patient's volume status. Indicators for the severe hypovolemic patients in the critically ill patients, there are the few indicators like that of hyperkinetic left ventricular cavity in presence of the normal RV. So with the end systolic cavity obliteration, the papillary muscle kissing sign, this is the one of the important signs for the hypovolemia. And here again is left ventricular end diastole area, if it is less than 5.5 square centimeter per meter square of the body surface area. And the third one is if the IVC is so small, that is less than 10 millimeter, but is still there is a good inspiratory collapse. So these are the few signs that shows there is a severe hypovolemia and patient needs a volume. There are certain dynamic parameters like that of passive lag raise has been proposed to predict the fluid response in the spontaneously breathing patients. Respiratory variations in the velocity time integral VTI may be used as an index of the fluid responsiveness, and IVC distensibility index like that of maximum dimensions minus minimum dimensions divided by the minimum dimension. If it is more than 18%, it has been suggested to predict the significant increase in the stroke volume to the fluid challenge. So the given fluid to the patient would be helpful. And in contrast, a high superior vena cava SVC distensibility index, maximum minus minimum upon divided by the minimum. If it is more than 36%, it predicts a positive response to the volume expansion. So these are the certain parameters which shows that given fluid to the patient may be helpful to the in critical care illness. So my next slide is for ECMO. So nowadays there are in critical care patients where ECMO is been very much used for the patients or the life-saving equipment. So echo is very essential in the pre-ECMO evaluation, and during the cannulation, echo is used for the proper positioning of cannula. So transesophageal echo is usually used during the ECMO cannulation. So these are certain parameters: the biventricular size and the functions, bilateral size and the volume, follow-up of any pre-existing pathology, volume status, presence of the thrombus, pericardial effusion, valvular regurgitations. These are the certain parameters we see during the ECMO cannulations, and assessment of the for the weaning in the veno-venous and the veno-arterial ECMO. So what is the ideal position for the ECMO? Because in the critical care, so this is the important question, what is the ideal position? The ideal position is achieved when the distal drainage port is located in the inferior vena cava and immediately below the hepatic veins. And the proximal drainage port, it needs to be located in the superior vena cava, and the return port must be placed within the right atrium and the return flow directed toward the tricuspid valve. As a result, venous deoxygenated blood is drained from the inferior and superior vena cava, and then following the ECMO, blood is returned straight in the right heart, avoiding the recirculation. So this is I have put this diagram just for understanding purpose. So these are the certain ports in the ECMO cannula. And here you can see that this is in IVC. So ECMO cannula seen in the IVC, and here is the normal antegrade flow in the hepatic vein, and this is the return flow in the right atrium directed towards the tricuspid valve. So next slide is very important slide, the role of the echocardiography in weaning from the mechanical ventilation. So in the weaning plan, cardiac echocardiography, when there is a RV dysfunction, RV systolic dysfunction, when there is a increased RV to LV area, the septal dyskinesia, and there is a reduced plateau pressure and the PEEP, we have to reduce the plateau pressure and the positive and expiratory pressure, and then again check the pulmonary artery pressure, which are aimed to normal volemia, consider the pulmonary vasodilators, and then we give the patient for the spontaneous breathing trial. If it is successful, then proceed to the weaning, but if it is unsuccessful, then we have to go for the next algorithm. In case of LV systolic dysfunctions, and like that of ejection fraction is less than 30% cases, E is more than A. In case of diastolic dysfunction, E by E dash is more than 8. And we have to just optimize the medical treatment, like that of use of the diuretics, inotropes, vasodilators, and the levosimendan. And then we have to start the pressure support and check again for the ejection fraction and the stroke volume and transmitral flow for the E and waves, E dash waves, again all these diastolic parameters, diastolic dysfunction parameters. And if it is stable parameters, then again we have to go for the spontaneous breathing trial, and then we have to go for the weaning process. So in weaning, again echocardiography is one of the important parameters. This is important slide again, because in the end of CPR, when to do end of the CPR, because during the CPR, bedside echocardiography has been used during the pulse checks to see the critical illness like that of pericardial tamponade, profound hypovolemia, or thrombus in the transit and acute cor-pulmonale. The absent cardiac contractility following a reasonable period of the CPR indicates the limited probability of the return of the spontaneous circulation. So when to end the CPR, it could be helpful by the use of echocardiography in case of critical care. So this algorithm approach for the differentiate and classify the shock by the echocardiography in case of hypotension shock. So first there is a visual assessment of the LV and RV size and the function, and then assessment of the stroke volume. So by the stroke volume, if there is a LVOT VTI is less than 18 centimeter, then it could be the obstructive shock. That could be there is a pulmonary embolism, that could be the cardiac tamponade or dynamic LVOT or the mid-cavitary obstruction. And in case, then again we have to assess the LV filling pressures, and if it is the elevated LV filling pressures, then it could be the cardiogenic shock. And if it is the LV filling pressures are normal, then we have to check again for the left ventricular and diastole area. If it is normal, then it could be the vasovagal vasoplegic shock, or if it is reduced, then it would be the hypovolemic shock. And if the LVOT VTI is more than or equal to the 18 centimeter, it would be the vasoplegic shock. Again, this is a hypoxemia. We can classify the hypoxemia by the use of echocardiography. First, again, there is a visual assessment of the LV and RV size and the functions. Then assessment of the LV filling pressures. If it is normal, then assessment of the RV and the pulmonary artery pressures. If it is abnormal RV functions or the pulmonary artery, then it could be the pulmonary embolism. And if it is normal, then we have to go for the assess for the intracardiac shunt, the contrast saline, contrast study, bubble study. Then if it is normal, then we go for the lung ultrasound as in the critical care. It could be the pneumonia, atelectasis or the pneumothorax. But if in case LV filling pressure is elevated, then it could be the hydrostatic pulmonary edema. So now I am going for a few cases we see in our day-to-day basis in our ICU to just mention how echocardiography plays an important role in the critical care. So my first case is the 52-year-old lady is admitted in the complaints of the fever, cough with the expectoration, generalized weakness for the last 1 week. Her blood pressure was 96 by 70 millimeter mercury, and he had a fever. She had a fever of the temperature 101 degree Fahrenheit, saturation is 96% of the room air, and sinus tachycardia with a heart rate of 112 per minute and decreased urine output. She was managed in the ICU with the IV fluids in view of the sepsis and antibiotic inotrope, but suddenly she got deteriorated and need for the ventilator support. The bedside echocardiography was done and it reveals. So this is my first case. It clearly shows the parasternal long axis view. It shows there is severe stenotic mitral wall. It's a hockey stick appearance of the AML doming. The color Doppler clearly shows there is a significant turbulence across the mitral wall opening. So in the 4-chamber view, apical 4-chamber view, you can see there is a mitral wall stenosis. So now the reason is clear why the patient got deteriorated, because IV fluid was given in the view of the sepsis, but she has a mitral stenosis. So by the use of echocardiography, IV diuretics was applied, and then fluid was curtailed, and she got further weaning by the ventilator. So here are the transmitral gradients. The significant severe MS, it's 15 millimeter mercury of the mean gradient, and the maximum gradient was 25 millimeter mercury. Next case, it's a 42 years old having the history of the chest blunt trauma injury in the 1 week back, admitted in the emergency department with the complaints of the breathing difficulty and the chest discomfort. His blood pressure was 90 by 60 millimeter mercury with the sinus tachycardia. Emergency department echo revealed. So this is a classical picture of the swinging of the heart. It's a cardiac tamponade. You can see the massive pericardial effusion. Here in the plex view, that was the short axis view, and here is the plex view. You can see there is a significant pericardial effusion. This is a classic picture of the pericardial tamponade. It is the swinging of the heart and the diastolic collapse of the right ventricle. So emergency, this patient was gone for the pericardiocentesis emergency. Next case is the 35-year-old young guy having the history of the palpitation, dyspnea, chest discomfort with the episode of the syncope during the climbing stairs on the strip. So emergency, in case of it was echocardiography which shows, here you can see this classical pictures of the hypertrophied LV. This is the asymmetrical septal of the septum, and there is a systolic anti-motion of the antemitral leaflet, SAM. So this is the case of the Hockham. Here in the color Doppler, you can see there is a significant turbulence and obstruction in the LVOT and secondary MR into the left atrium. This is a classical 4-chamber picture. This is it's a hypertrophied LV, significant hypertrophy, and here are the pressure gradients across the LVOT. It's a 63 millimeter of mercury, the significant LVOT gradients. So this patient was further planned for the septal alcohol septal ablation for the management. Next case is the 71 years old admitted with a fever, breathing difficulty, decreased urine output, episode of pre-syncope. He was admitted in the critical care. TLC were 21,000, chest X-ray suggestive of consolidation. He had a low blood pressure. He was managed on the lines of the sepsis. Inotropes were initiated and echocardiography was called for. And here you can see in the parasternal long axis view the aortic valve. You can see it's a classical calcified aortic valve and the stenotic valve. In the color Doppler, you can see there is a significant turbulence and the mild aortic regurgitation also there. Here in the 5-chamber view, apical 5-chamber view, the aortic valve is stenotic and completely calcified. And here are the transaortic gradients. The significant gradient, mean gradient is around 49 millimeter of mercury, and the peak gradients are around 71 millimeter of mercury. So this was the case of the severe calcific AS, and the patient was further planned for the aortic valve replacement. The next case is a 58 years old lady admitted in the neuro ICU with a history of the left-sided weakness for the last 2 days, and CT scan suggested large MCA infarct, and she had a history of the coronary artery disease post CABG old MI with a severe LV dysfunction with the ejection fraction of 30%. So bedside echocardiography which showed. Again, this is a classical picture of the LV apical clots. Here even in the plex view you can see the significant thrombus. So in the 4-chamber view you can see there is a multilobar clots thrombus, the mobile one. So this patient anticoagulation was started, and the cause of the large infarct was revealed by this echocardiography etiology. Again, 67-year-old male admitted in ICU, diagnosis of UTI sepsis with the raised blood counts, reduced blood pressure, decreased urine output, deranged RFT, LFT. Inotropes, IV antibiotic initiated, but condition was not improved. So echocardiography was done, and here you can see in the short axis there is a global LV hypokinesia. In the plex view, you can see there is a significant MR. Its 4 chambers shows all 4 chambers are dilated. So this is a case of the dilated cardiomyopathy with a significant severe eccentric MR. It's 44-year-old farmer had a severe chest pain while farming and presented in the emergency department. The quick echocardiography which revealed. So here you can see there is a significant intimal flap in the plex view in the aorta. You can see that this is the case of the aortic dissection. So in the 5-chamber view, you can see there is a significant flap. You can see echogenic intimal flap. So a patient was rushed for the Bentall surgery. Then 31 years old guy got a tattoo followed by a fever, altered sensorium, deranged RFT, and then later on got a splinter hemorrhage. And echocardiography was done, which shows you can see that there is a significant vegetation in the plex view, the aortic non-coronary cusp. So in color Doppler, you can see there is a significant aortic regurgitation. So he was managed with the IV antibiotics. Second last case, it's a 55-year-old male admitted in the CTVS ICU with the diagnosis of coronary artery disease, acute inferior wall MI. It's a 3-vessel disease with the moderate LV dysfunction. He had an ongoing angina with the pansystolic murmur. So this echocardiography, you can see in the subcostal view, there is a significant ventricular septal rupture. Here in the short axis view, you can see there is a ventricular septal rupture, and this is a color view. This is a shunt in the left to right. The last case is 29-year-old lady admitted with a history of the fracture right tibia 2 weeks back, followed by the chest discomfort, breathlessness for last 2 days. Her blood pressure was 102 by 70 millimeter mercury, sinus tachycardia 123 beats per minute, and echocardiography shows there is significant dilatation of RA-RV, and this is a paradoxical septal motion. This is a case of acute pulmonary embolism, significant TR, significant pulmonary artery pressures, and here in the CT scan you can see there is a saddle thrombus. Thank you.
Thank you, Dr. Himan, for a beautiful lecture on use of echocardiography in critical care setting and how with a simple echo machine we can diagnose multiple things. Due to paucity of time, we will go to the next lecture and then we can take the questions. The next talk will be by Dr. Ritu Agrawal on role of MRI in cardiac arrhythmia.
We would like to invite Dr. Arif Khan sir to chair the session. Dr. Arif Khan.
I would, good afternoon, everybody. First, I would like to thank Dr. Makan and his team for having me here. So without taking much of your time, I would like to talk today about the role of MR in cardiac arrhythmias and basically answer the question, why do we do a cardiac MRI, which is a potentially expensive and a lengthy test. It takes around 40 to 45 minutes for the patient to have a good study. So CMR is essentially a one-stop shop. You can do you can have a functional assessment, you can have an assessment of perfusion, you can see the myocardial scars and which on a late gadolinium enhancement sequence. And then we have the newer sequence such as the T1 and the T2 mapping, which can detect edema as well as the scar even before it becomes apparent to the naked eye. And then you have the classic edema-weighted sequence, which helps us to see the myocardial edema. So when a patient comes to the electrophysiologist or a cardiologist, these are the 5 potential problems that often happen. And the diagnosis is at least suspected before the patient is being sent for CMR. So it's naturally okay for the cardiologist to assume that जब मुझे diagnosis पता है तो मैं क्यों भेजूँ cardiac MR के लिए? And I am trying to actually answer that question for all of you. There are 5 slides, each of them having one case and all these 5 cases, and I try to answer the question, why CMR? So that's a patient with suspected cardiac sarcoid. He's a young guy in his 40s who had 2 episodes of VT, was revived, and there was some contraction abnormalities on echocardiography. EF was more or less normal. It was around 40s and 50s. And now when you see a cardiac MR, you can see very well the dyskinetic movement of the interventricular septum. Besides that, the EF seems to be pretty normal. Then you have the, Then you have this is a post-contrast image. You can see there is a fair degree of myocardial, mediastinal lymphadenopathy. That is the aorta, the arch of aorta, and these are the arteries coming from it, and that's a mediastinal lymphadenopathy. And now when you see the post-contrast images, these 2 are the post-contrast images. So here the black is the normal myocardium, and whatever stands out white is the scar. So a cardiac sarcoid will give us a subepicardial scar. Sometimes that becomes transmural, as you can see here, and sometimes you have mid-myocardial scars. Now the point to note is that the non-ischemic cardiomyopathies will never give you only a subendocardial scar. The differentiating factor of these on MR from a ischemic cardiomyopathy is the presence of scar in a subendocardial scar in a coronary artery distribution. However, as the degree of ischemia progresses, the scar extends from the subendocardium and becomes more or less transmural, but it always starts in the subendocardium compared to in these non-ischemic cardiomyopathies where the scar is more of subepicardial and then becoming mid-myocardial. And then on the short axis images, we have this classic hook sign where you can see a subepicardial scar along the enteroseptum, mid-enteroseptum, and then extending along the insertion point to involve the RV. So, so that was a case of cardiac sarcoid. Now, what does MR offers in addition to what you already know? In a patient, when you have a clinically suspected cardiac sarcoid, and then there is no contrast enhancement, there is no LGE, which is late gadolinium enhancement. It is called late because we do a delay period after injection of contrast, which is gadolinium. So that is why the sequence is called LGE, or late gadolinium enhancement. And then if you have no scar or no late gadolinium enhancement, then the incidence of VT and sudden cardiac death are extremely, extremely low. And you can be more or less convinced and send the patient home happily. Now, if the patient on suspected cardiac sarcoid and there is no LGE, then it essentially rules out a cardiac sarcoid, and no further workup for cardiac sarcoid should be pursued in these kind of patients. And an alternative explanation for the arrhythmias and the ECG abnormality should be sought. That is a patient who comes with suspected hypertrophic cardiomyopathy. So again, on echo, the diagnosis of hypertrophic heart is already made, and then the patient is sent for CMR for further information. So what does CMR do in these patients? In these patients, a CMR would show you the exact pattern of cardiac hypertrophy from the basal septal hypertrophy to focal sigmoid to apical to again a focal vent myocardial, focal hypertrophy to mid myocardial with apical ballooning or the other variants. So it gives you the exact morphology of the myocardial hypertrophy. Then it answers a very important question, whether it is hypertrophic cardiomyopathy or it is a cardiac hypertrophy due to some other cause, whether it's athlete's heart, where you have a balanced four-chamber dilatation and no scar, whether it is a hypertensive cardiomyopathy, where again you will have a basal septal hypertrophy and no scar or a very little scar, whether it is an aortic valvular disease, where you will have a concentric hypertrophy and a aortic valve problem, again the scar would be very less, or it would be a deposit disease such as Fabry's or amyloid, again the pattern of scar will be very different, or it is apical hookworm, which is often missed on echocardiography. Then MR would also help you to see the presence of LVOT, classifying it into hypertrophic versus hypertrophic obstructive. This can actually be done better on echo because you can also do a stress testing with a Valsalva on echo, which is not possible with MR. However, MR also assesses for the subvalvular problems and the valvular problems. It looks for the mitral leaflet length, and a long AML is often associated with more degree of SAM because it's easier for the valve to get sucked in the LVOT. It tells you about the anomalies of the pap muscles, the pap muscle scar, abnormal attachment, and so on. And then you can have other cause of LVOT obstruction, such as a subaortic ring or a membrane, which can be very well seen on MR. Now, MR is a single modality which will calculate the exact end diastolic thickness. And this thickness has a prognostic implication. Again, we can see an exact LV and the RV function on MR. In case of burnt out HCM, where we have a dilated pattern, this is again is very useful. Now, the pattern of scar can be well seen. As you can see on this image, this black is a normal myocardium, and then the classic mid-myocardial scars is the scar of hypertrophic cardiomyopathy. And then these are the T1 maps. So what does this do? On these, we draw certain numbers. We calculate it, the software does partly and the radiologist does partly. And then this will, if the T1 number is abnormal and there is no scar on this, then you know it is abnormal because the T1 map is essentially more sensitive than the late gadolinium sequence, and this will pick up the degree of scarring before it becomes apparent on this. So it allows us to calculate, and then there is software which allows us to calculate the percentage of scar over the total myocardial mass. So it calculates the volume of myocardium which is scarred and divided by the total myocardial mass and gives you the percentage of scar, which is prognostic indicators. Now there is no definite cutoff. There are multiple papers, but usually accepted number is 15 to 20%. If the myocardium is scarred, then it is one of the indications for putting a primary ICD, and a hypertrophy more than 30, again, puts the patient of higher risk of arrhythmias. Case 3 is when the patient presented with dilated RA-RV and you suspect ARVD, and then again the patient is sent for CMR to confirm or to rule out other possible causes of dilated RA-RV. And then you can see here, this is it is a still image from the SSFP sequence, which is essentially calculates the function. You can see here there is some degree of microtrabeculations, and these are actually the focal dyskinetic movement, dyskinesis of the RV free wall. That's a post-contrast imaging showing you the scar on the RV free wall. That's a LV predominant ARVC when you see a scar on the LV wall, a subepicardial non-ischemic pattern of scar, and the RV appearing normal. So we have the revised 2010 task force criteria, the major and the minor, based on which we diagnose ARVD on MR. So what does MR do? MR establishes the diagnosis. It differentiates from other cardiomyopathy, which can cause dilated right ventricle, such as sarcoid, myocarditis, athlete's heart, dilated cardiomyopathy, RVOT, VT, and Brugada syndrome. And then it can also be used for follow-up of additional family members. Though there are no abrupt guidelines, no cut-off clear guidelines, but usually the opinion is to screen every 2 to 5 years with echo and CMR whenever available. And it again has a very high negative predictive value for cardiac events. So if the cardiac MR is normal, then there is nearly 100% negative predictive value for adverse cardiac events. That's another potential scenario when you have a patient with arrhythmia or some rhythm problems and suspected myocarditis. This is usually a young guy where the possibility of ischemic cardiomyopathy would be very low. Again, CMR has a lot of to offer here. That is an edema-weighted sequence, and as you can see, there is this increased signal in the lateral myocardium, suspecting there is myocardial edema. That is the early gadolinium enhancement when you can see there is patchy increased signal, white areas in the normal gray myocardium, suspecting there is some degree of enhancement. You can also see there is a trace pericardial effusion and bilateral pleural effusions. And this is a post-contrast image where you can see this classic patchy mid-myocardial to subepicardial scarring in the same area where there was edema. Also, there is a pericardial enhancement showing that this patient is a classic case of myopericarditis. So these are the Lake-Louisi criteria for diagnosis, and if 2 of these are positive, then we know we are dealing with a case of myocarditis. Now, what does MR offer here? Again, if the patient coming with acute chest pain, the coronaries are normal, and he has some recent viral illness or other potential history where you suspect a myocarditis, CMR rules in or rules out the diagnosis, and thus allows modification of treatment like stopping of anticoagulation therapy. If there is a patient of acute or progressive heart failure, MR acts as a gatekeeper for endomyocardial biopsy. And then if the patient has non-specific symptoms, then again MR would rule out or rule in myocarditis and avoid further testing. That's a fifth potential case when you have a case of dilated cardiomyopathy. On MRI, you can see this is a case where you are seeing some basal contraction. The basal segments are contracting, however, the mid to distal segments are ballooned out, dilated, and there is no scar, so that is classical Takotsubo. That is a still image from LBB cardiomyopathy where you have some abnormal septal motion, but there is no scar. And that is a case of a non-compaction where you have non-compacted myocardium more than the compacted myocardium with a ratio greater than 2:3:1. So MR again differentiates whether it is a ischemic dilated versus non-ischemic, and then in the non-ischemic group, it will tell you whether it is what type of non-ischemic cardiomyopathy it is, and thereby it targets patient symptoms versus what kind of therapy the patient should be given. It acts as a pre-implantation to CRT, allows accurate calculation of the EF. And then it again is important for judging the response to therapy. It allows to diagnose the intercavitary thrombi and also allows for risk stratification by all the above information it does. So what does CMR do? CMR allows a diagnosis, but it goes beyond diagnosis for risk stratification, planning of treatment, follow-up, improve understanding of pathophysiology of the disease. It allows for screening of family members, and overall it reduces mortality and morbidity. Now that is one additional case who is a young guy who came with NSVT and VPC, and we can see a classic ring pattern of scar, a very impressive scar in this patient. So when a patient comes with NSVT and the ECG and echo are normal, if you have a late gadolinium enhancement on CMR, then it is associated with increased risks of major arrhythmic events on follow-up. And you have, when you have this pattern of mid-myocardial or subepicardial ring-like scar, then that is associated with a particularly high risk of arrhythmic event. So what does it do? It tells you that MR should actually be included in the workup of patient of idiopathic NSVT, and this is probably one of the questions one of the faculty asked in one of the talks. So yes, MR should be done when the patient has NSVT and everything is as normal before a cardiac MR, because it will help you to identify if there is a potential scar, and if you have this ring-like pattern of scar, you have to be more aggressive in your management of these patients. So the take-home message is with the tissue characterization by using LGE and the T1 and the T2 maps and the evaluation of the cardiac function, CMR is a very important role in evaluation of cardiac diseases, and we have these newer mapping techniques which are helping in understanding the pathophysiology of disease. We are actually on the way to develop more faster sequences, bringing down the scanning time, and then we have increased awareness among the patients and the cardiologists, and improved paying capacity is likely to increase the utilization in future. Thank you for your time.
Thank you, Dr. Ritu. A very good presentation of how the MR can help in the cardiac arrhythmias. Any further questions anyone has? I have a question for you, Dr. Hemant. Can somebody pass the mic to Dr. Hemant? It's been like you have around a decade of experience of doing an ecos and everything now. Sometimes when we are given a call in ICU to get an echo done of a patient who is in arrhythmia, then we need to see for the structural things also. Yeah. And sometimes there is any valvular heart disease and we have to see for the gradients and everything. How in those cases do you assess the gradients or the valve area, and what is like the criteria of yours into this?
So in case when we see this type of patient, because in case of the AF like that of fast ventricular rate, or in the patient with the arrhythmia in the patient, in such cases, because when we go for any structural assessment of the valve or anything, because the time we go for the assessment of the any valve, we need to get a better hemodynamics, the stable one. Okay. In case, because we go for a assessment of any valve or something like that, at that time if the patient is in AF in the fast ventricular rate or in a VT or something like that, because at that time the first initial assessment could be done. But again, we have to mention in our reports, because this is the hemodynamically unstable patient, we have to get a review of this patient once it got stable. So the initial review, because morphologically assessment of the valve is very important, because sometimes we can have a hemodynamically assessment of the gradients, Doppler. It could be influenced by the heart rate, it could be influenced by the blood pressures, it could be by the unstable conditions. But the morphologically assessment, we can see what is the primary thing, what is the valve condition, either it is the stenotic one or not. And similarly,
Hello.
Similarly, in case of like that of in ARVD patients, so we have to just carefully see in these patients that whether there is any focal abnormality in the right ventricular free wall, is there any focal aneurysm or not. And in case of like that of in the HOCM patients, so in such cases patients, because sometimes when we go for the LVOT gradients assessment, so in that case when there is a high tachycardia rate, or in case of there is a blood pressures, it could be influenced by that, the gradients could be influenced in that situations. So in such cases, we have to just assess primarily, and again we have to review once the patient got stabilized. Thank you. Anyone?
So thank you very much, sir. So before we wrap up today's session, we would like to express our heartfelt gratitude to the distinguished speakers who have enlightened us with their insights and expertise. Their contribution have truly enriched our understanding of various cardiac-related elements. Today we have the privilege of presenting memento to our esteemed speakers. So I would like to invite Dr. Daljit Kaur, Dr. Ajay Nayak sir, and we are honored to have Dr. Jitendra Singh Makkad and Dr. Kush Bhagat sir to present those token of appreciation to our speakers. So let's give them a round of applause for their invaluable contribution. So may I request Dr. Ajay Nayak sir. Please come forward. May I request Dr. Sanjeev Sidana, sir? Dr. Hemant Chaturvedi, sir? Dr. Ritu Agrawal, madam? So give them a big round of applause for their invaluable contribution. Thank you all for being a part of this enriching journey. So now I would like to invite Dr. Jitendra Singh Makkad, sir, to say something about the conference and vote of thanks.
Thank you, Nitesh. For that, I'll like to Kush to stand with me. Dr. Kush is my younger brother, my student, my colleague, and now the leading part of our EP team. He doesn't need thanks, but he definitely deserves a great round of applause because he's single-handedly handling this conference now. I started JHRS, but now he owns that, and hopefully we continue doing like this. I was busy in a big function called Voice of Doctors till 30th of July, so I couldn't pay any attention to this conference. But I think all of them in leadership of Kush has done wonderful job to bring this to this kind of success. So I start by thanking our national faculty, especially Dr. Ajay Naik sir, who has always been kind and to accept our invitation and throughout being there for the scientific session. Your intermittent discussion and guidance always works. Thank you very much, sir. Dr. Noop Gupta, he has left, he had a flight. So similarly, he is also always part of our conference and very courteous to attend the full session. Dr. Daljit has attended first time the JHRS. I hope you become part of our team and attend it every year. And your expertise in EP is definitely needed for the young budding EPs, the kind of work you are doing with your team in Hyderabad. So thanks to Dr. Claire, Dr. Saxena, Dr. Parna, who were attached online, they couldn't come, and Dr. Niti, who left early in the morning. So she also new part of our faculty, and hopefully we continue with them. So our local faculty from Eternal, Dr. Sanjeev Sharma, Dr. Sidana, Dr. Hemant, Dr. Ritu, Dr. Atul Kasliwal, thank you very much for their for your important contribution as a speaker. And our senior cardiologist, Dr. Dipender sir, is always here for encouragement, and other senior cardiologist, Dr. Sahil has come all the way from Ganganagar. Thank you, Sahil, for attending this conference. Dr. Sunil Benwal, Dr. Ram Chitlangia, Dr. I'm forgetting a few names, but I saw a few senior cardiologists. Dr. C.B. Meena sir and Sunil Beniwal, Supriya, who is part of our department now, and they all attended this conference as a faculty and enriched with their experience. Then we have company of very senior physicians here. Thank you, all of them, especially the HODs, Dr. C.L. Naval sir, who attended today, and he sent his residents, and one of his resident won the quiz yesterday. Thank you, sir. Thank you so much. And various HODs, Dr. Puneet Rizwani from Mahatma Gandhi Medical College, Dr. Sudhir Mehta were courteous enough to send their residents. And also our cardiology department, Dr. P.V. Agrawal sir, Dr. Bagretta sir, who sent their residents here. And I thank all the audience who attended this, including our resident students who were there in large number yesterday, and made the first session of ECG quiz very, very successful. And we look forward to doing more frequently than once in a year. That enriches us also with the fresh knowledge of ECGs. Then obviously in any conference we need a lot of money, and our industry is always courteous enough. So I thank Medtronic, I thank Abbott, Biotronic, Boston Scientific to contribute very generously every year, maybe twice in a year in some or other way they contribute, and these things are not possible without their contribution. And I don't know what is going to be the future, but till now I think industry and the fraternity go hand in hand as far as development of therapy is concerned, awareness of therapies are concerned. This is not a one-way thing, but industry is always part of it. Then our pharma colleagues, obviously with their financial contribution as well as physical contribution in invitation and all kind of preparations. So I'll thank Aris Pharma, then Sun Pharma, Torrent Pharma, USV, AstraZeneca, Lupin, Novartis, Intas, Bayer, Cipla, Pfizer, Eucardix, and Smart Cardia, the ELR guys. Thank you so much. A great round of applause for our colleagues who are standing behind. Without you, this gathering is not possible. और जो last overs में आप लोगों ने बैटिंग की है, उसी से हम जीते हैं. So with a good margin. Thank you so much for being with us always. And then our own marketing department led by Nitesh ji is very crucial part of this conference, and Eternal is our heart, and Team Eternal, thank you very much. So Nitesh ji, you are a very good leader, and you took part as an anchor and spared 2 days. Thank you very much. Beside that, his team, Vikrant, Ashish, Prashant, Faiz, Ramesh, all great round of applause for all of you. And I should not forget thanking our MD and co-chairperson Manju Sharma ji, and our CEO Prachish, and our medical director Dr. Manmeet to contribute in all the means possible to make this successful. And our permanent event partner now, Vision Plus, led by Navneet. These guys has done wonderful job. ये जो लास्ट में हुआ, ये तो नितेश ने बोला, ये तो शंखनाद था एक सक्सेसफुल टीम. बाकी कोई भी आपने जरा सी भी ऑडियो विजुअल प्रॉब्लम you must not have seen in last 2 days. So this is how flawless, and their screen is also getting curves. बड़ी figures होती जा रही है day by day. So thank you very much for all your contribution and your dedication. And I also thank the band we had yesterday. I think all of you had great fun last night. So I'll convey the thanks to them also to make that night beautiful. And our media team led by Rajdeep, we are having a good coverage. आज डॉक्टर अजय नायक, डॉक्टर दलजीत कौर के नाम से खबर छपी है हमारी अखबारों में. So that is done by our media team. Thank you very much, and thank you all the Marriott staff for taking great care of us. Thank you so much. I am sorry if I forgot a few names here, but I am grateful from core of my heart to everyone who is standing here at this moment when we are finishing this conference. Thank you so much. Thank you once again.
So I think, sir, we can proceed for lunch. Thank you so much.